Good morning. I'd like to welcome everybody to the Noca annual conference for 2022. The title of our conference this year is Data Driving Quality. I'm just going to put up some slides. Bear with me. My name is Dr. Brian Creedon. I'm the clinical director with Noca since 2019, and I was also involved formerly as a clinical lead with the National Audit of Hospital Mortality. And just to take you through some brief housekeeping, presentations from all speakers will be available on the Noca website, as will be recordings in the next 2 days. We would encourage those who are active in social media to use our Twitter handle at Noca_IRL or the hashtag Noca 2022. CPD is as described there. There are 3 CPD credits with the Royal College of Surgeons of Ireland and outside the Nursing Midwifery Board of Ireland. And a CPD cert will be issued electronically within 1 month. There is, using the portal, there is opportunities to ask questions today. On the right-hand side of the portal, you see your questions tab that can be opened to ask questions for the presenters, and we can take those in turn. And there's also, on the information, there is the timetable for today's presentations. We'd encourage you all to ask questions through the day, even during a presentation. We'll have our first questions and answer session at 12:25, although we may have a few minutes to take some questions after the launch of the Irish Heart Attack Audit. Okay, so moving on, it's apt today that it's just over 10 years since the Noca, the National Office of Clinical Audit, commenced, and we're celebrating that today. It's started in 2012, and some of those who were involved initially are still involved today. Mr. Ken Neely, who was initially the clinical director, is now chair of the governance group, has been involved and with Fiona Hammond as the first executive director, would have had the vision to use quality to drive improvement in patient care and help us improve the care that we provide to the public and patients. We now have a team of 21 staff working with Noca, 21 colleagues, and that's soon to grow by 2 more. Noca has published 27 national reports with accompanying summary reports to date. Our large group of public patient interest representatives have been integral to helping us shape our audits and communicate our audits to the wider public. We have published 2 feasibility studies with a third due for publication in May, and that's the feasibility studies at potential national clinical audits in other areas. During the pandemic, we published 6 interim COVID rapid reports, and this allowed us to provide some rapid learning during the pandemic and how our health service was responding to certain aspects of care. We've published 2 strategies and are currently a year and a half into our second strategy. I think when we look back, we had 260 people at our first conference in 2015, and we've over 1,200 online today. So the interest in using data to drive quality is only growing, and that's very heartening for us. And there's constant learning for all of us who are involved in clinical audit. I'd like in particular to thank all those who submitted to the Noca Quality Improvement Champion Awards this year. We had a large number of submissions, all of a very high standard, and it really was truly difficult to shortlist the 3 which will be presented later today on the podium, our podium presentations later today. So, as I said, in 2012 we had the launch of Noca. Following quite soon afterwards, we started establishing the Irish HIPE fracture database, and this has been responsible for significant improvements in the quality of care afforded to those patients who have a fracture or broken neck or femur and their care pathway in hospital. It's allowed us to drive allowed healthcare providers to drive a lot of quality improvement. This was closely followed by our major trauma audit of the MTA. And again, this has shaped how we're going to provide trauma services in the future, which I'll mention in a minute. Our alignment to NPEC was sealed in 2014, and we've worked very closely with the National Perinatal Epidemiology Centre in Cork, led by Professor Richard Green. And the rollout of our Irish National Intensive Care Unit Audit and the National Audit of Hospital Mortality began in 2015, as was our first conference. We now have 22 intensive care units participating in our ICU audit, and moving on then to 2016, we had the commencement of the development of the Irish National Orthopaedic Registry. Again, this is a really exciting project that has published its first report recently. It involves 10 public sites and 1 private hospital site, with other private hospital sites to follow. And it looks at interestingly at patient-reported outcomes related to arthroplasty or major joint replacement, mainly hip and knee, and will be responsible, I think, for allowing us to ensure that we continue to offer efficient care and providing assurance about outcomes for patients and the wider public. In 2016, we know that the major trauma audit was the first national clinical audit to receive National Clinical Effectiveness Committee endorsement from the Department of Health. And following close on, in 2018, the major trauma audit was assisted in the development of a trauma system for Ireland report, of which we're currently implementing. Noca was one of the founder members of the European Clinical Audit Network, ECAN, and has worked closely with the Dutch Institute for Clinical Auditing, or DICA. In 2019, Noca welcomed the Irish National Audit of Stroke and the Irish Heart Attack Audit, which will hear later from today at its first annual report presentation. We have also been involved in publishing GDPR guidance for those involved in clinical audit in 2018, and all these resources and reports are available on our website. In 2019 as well, we were commissioned by the Chief Clinical Officer, Dr. Colin Henry, who will speak later, to assist in a national review of clinical audit. This was an output of the Professor Gabriel's Galley report. And this is heartening to see the HSE establishing the National Centre for Clinical Audit this year and helping us have a better platform for delivering on clinical audit, both locally and nationally in clinical audit. I think I should mention at this stage that Noca would not be here if it was not for the support of the HSE, and in particular Dr. Philip Foley, who provided huge support and assistance with us in the early years, and also Dr. Orla Healy, the National Director of Quality and Patient Safety, who has taken up post last year. In 2020, at the commencement of the pandemic, our intensive care colleagues and working with Noca, we were able to launch the bed information system, and this allowed us a live platform to see where the usage of intensive care beds during the pandemic and where there was availability. And this was really important to ensure those patients that needed escalated care could access an intensive care bed, and it also allowed for healthcare planning. The National Paediatric Mortality Register also joined Ireland that year, transferred from where it was housed under the governance of Temple Street. We also, as I mentioned, were involved in some audit feasibility studies, which continues, and we also adjusted our dashboards and reporting to healthcare providers and to hospitals to allow quarterly dashboards and for access for those healthcare professionals providing care to see real-time data and to allow it to shape their care. As I said, we published our strategy last year in 2021, which will run for 5 years. And there was also the first report of the Irish Paediatric Critical Care Audit. We've been involved in some research opportunities, working with Stroke and RCSI, and also with the major trauma audit has done some work for the national, continues to do some work for the National Ambulance Service and the Trauma Office and the HIPE Fracture Database, And we were also engaged with some work last year with Michael Sykes and the HSE, the National Quality and Patient Safety Office, regarding audit and quality improvement. Our PPI reps are central to everything that Noca does and our success, and particularly allowing us to focus on what's relevant for patients, and also ensuring that our communication with the wider public through our summary reports and also through media engagement is relevant and understandable. And we have public and patient interest representative on every governance committee for every database and audit, as well as on our governance board, and they have really truly been central for success in delivering efficient healthcare and opportunities for improvement. So as we look to the future, move forwards, we will be moving rather towards interactive dashboards to allow more easier engagement by those conducting clinical audit, expanded audit portfolio beyond acute care, and hopefully trying to have national clinical audits and patient reported outcomes that traverse domains. So whether you're in an acute hospital or a number of acute hospitals or in the community, that we will be able to follow the care of those patients and look at longer term outcomes. Obviously, a facilitator is the individual healthcare identifier, which we're hopeful will arrive soon, and electronic health records, EHR, will also help. We want to continue to allow audit, national clinical audit, to evolve and demonstrate its impact, and that impact being central to how we evolve and shape clinical audit and links to quality improvement and helping those who are providing care and delivering care to see opportunities for improvement and how to do that. I think what's important is, particularly important is, as we collect more data, that we refine that data and we have a sensible or efficient use of data. These data points as well should be made as easy as possible for collection, that we're not doing double entry, that data is collected at one source and then shared, and reducing that burden of data collection. And also to promote transparency, that's the sharing of national clinical audit and our registry outcomes with the public, with service users and patients, with funders and with healthcare professionals, to allow all of us on a journey of delivering ideally quality improvement and efficient healthcare, and with the essential input of our PPI reps. As I said, if you have any questions, please feel free to put them in the question and answer box on the portal. Now, I'd just like to introduce our first speaker, who doesn't need much introduction, Dr. Colin Henry, who's the Chief Clinical Officer of the HSE. Colin took up this post in 2018 and has been central during the pandemic in communicating and leading the response of our health service to this unprecedented event. He has a long history of leadership in healthcare, serving as a clinical director in the Mercy University Hospital, as well as national lead for clinical directors and a national clinical advisor to the hospital, for acute hospitals. In his role as the first Chief Clinical Officer, he's been responsible for aligning clinical expertise and leadership across our healthcare system, from service and policy design to planning and implementation. And the core function of his post is to ensure the implementation of clinical models of care to respond to the needs and challenges of healthcare at this time in the 21st century. He's also been responsible for setting quality and patient standards across the healthcare system, and has been a long supporter of the work of Noca. Without much further ado, I'd like to hand over to Dr. Paul Henry. Thank you.
Noca.
You're on mute.
Sorry.
Okay.
Okay, so thank you to Brian and Colette and to Noca, and congratulations on reaching this milestone. It's a wonderful time to pause and to acknowledge the huge work and driver of change that Noca has been for the good. It's become a great force for the good in Irish healthcare, and we see that how the audits have grown organically to drive change in some of the some of the most significant areas of healthcare, including trauma. I'll touch on that later on. And just to the simple act, as we know, of audit, of simple act of gathering information in a standardized way and presenting in a way that invites comparison, we know leads to improvement. I've used this quote before from Florence Nightingale, which in previous presentations, but it's as apt now as when she first wrote it in 1863. When she wrote, "There's growing conviction that in all hospitals, even in those which are best conducted, there's a great and unnecessary waste of life. In attempting to arrive at the truth, I've applied everywhere for information, but in scarcely an instance have I been able to obtain any records fit for purposes of comparison. If wisely used, these improved statistics will tell us more of the relative value of particular operations and models of treatment than we have means of ascertaining at present." And this really eloquently summarizes the work of Noca in those landmark publications and reports that characterize its journey over the past 10 years. It's by allowing us to present data, information in an agreed standardized way, and to compare it between hospitals or between institutions, allow us to draw conclusions about the relative value of healthcare or areas of improvement. And it certainly has led, as I said, to some of the major strategies that we've seen in Irish healthcare in recent years. Next slide, please. Here I summarize some of the expanding portfolio of Noca. Most recently, Irish Heart Attack Audit, which is being launched, a hip fracture database, an important driver for change again, and to acknowledge the work of Emer Ahern and others in that work. The Irish National Audit of Stroke, Joe Harvest and Ronan Collins. The importance of leadership, clinical leadership in all these areas is critical in terms of gaining the confidence of the clinical community, and in terms of hammering home the key messages that arise out of all these audits. The ICU audit has played a pivotal role in the pandemic over the past couple of years, and the community there were very supportive, and were able to show through their work, which showed remarkable agility at adapting to the pandemic, that our outcomes in that first phase of the pandemic in ICU were significantly better than countries whose healthcare systems were overrun during those first few months of 2020. But then when our own healthcare system became under huge pressure in the early months of 2021, including our intensive care, we showed that audit showed how that translated into outcomes in ways that we could measure against other countries. An Irish National Orthopaedic Register, the major trauma audit, of course, again, with Conor Deasy and Colette's input again, has now that is now a government-sponsored strategy and policy, and we're well on the way to implementing this through the establishment of major trauma centres based around 2 networks in Cork and Dublin, and more recently we're now describing the core components through Keith Sinnott of what a trauma unit should have. And again, these improvements, these strategies were driven and triggered by these audits. The simple act of recording how patients with major trauma were treated, where they were treated, and how they were transferred, what kind of injuries they suffered, and so on, led to that national strategy. The other ones I mentioned: National Audit of Hospital Mortality, Paediatric Mortality Register, National Perinatal Epidemiological Centre by my colleague Richard Green, all landmark audits and reports over the past 10 years. Next slide, please. And of course, those reports I've mentioned already, which we've all grown used to, become part of our landscape now, and all harnessed in different ways to drive ongoing improvement, and staying faithfully close to that cycle of audit, of measuring, comparing, and improving. Next slide, please. Critical part of I want to mention, not Colette and her team, but also the clinical leads. I've mentioned some of them already, and this is a critical component of clinical audit. It ensures confidence of other clinicians that the audit is measuring something worthwhile, an area of interest where we know there may be variation in the quality of care, an area where we know there may be improvement, an area that may require investment. It's important in the design of an audit. It's important in the quality of the data. And perhaps most importantly, it's important in the interrogation and the interpretation of the information that comes out of it. It's that end piece of clinical leadership, which brings that, explains this to not just the clinical community, but to the wider public, and what needs to happen as a consequence. So just to pay a special mention to those clinical leaders in all these audits over the past few years. I mentioned Emer Ahern, Conor Deasy and others. and they've had a critical role in enhancing the quality and transformation of clinical services. Next slide, please. The COVID pandemic has been a huge learning for us for the past few years. Perhaps I'll go on to some of the major, but perhaps more so than anything else is how important our staff are. Our staff throughout healthcare, throughout Ireland, in all forms of healthcare, community and hospitals, have had an exhausting 2 years. They themselves have had to work under very difficult conditions with new infection prevention control requirements, with PPE, with the perpetual risk of acquiring COVID, and to remind everybody, they had to work at a time when there was no vaccination and all the risks that entailed. And any audit, any improvement cycle, anything we do, any of these reports, we must be able to speak with the results, speak to our staff and engage with them and ensure that the message and what flows out of all these audits is important to them in their workplace. And that's why this local component is so critical. Next slide, please. The COVID-19 pandemic, of course, demonstrated the fragility of well-developed healthcare systems across Europe. When it seemed remote in China, it was somewhere far away. Then we saw a very well-developed healthcare system in northern Italy collapse. We saw intensive care units and hospitals in London under huge pressure. And in the early part of 2021, as I said ourselves, our own intensive care units and hospitals came under huge pressure, where we saw suspension of all non-essential activity, redeployment of staff at scale into intensive care units and high dependency units, and still our hospitals under huge pressure. And this, what was discovered not just in Ireland but abroad was how fragile healthcare systems were in the face of a pandemic. And the major learning we have, of course, is the first is how valuable public health is to our healthcare system. And I'm happy to say that we have a much more stronger, more resilient public health system in Ireland now as a result of substantial investment into public health departments and a reform programme of public health, which will see it integrated into one cohesive structure within the HSE. We understand as well that the impact of the pandemic was highlighted the issue of health inequality, and particularly the poor outcomes for those who are vulnerable and marginalised. It highlighted as well the importance of strong public engagement and the importance of having robust preparedness plans for future health threats. The other significant learning for us, the other two, was innovation healthcare. We had talked for so many years about new forms of healthcare, about virtual clinics. We had piloted schemes in fracture clinics, in heart failure clinics, never substantial investment, but suddenly at speed, we had to invest in forms of healthcare to avoid footfall in hospital. We found ourselves rapidly scaling up forms of healthcare delivery that previously had only been piloted or even proposed or never got off the proposal page. And we saw widespread adoption of digital healthcare solutions and the shift of delivery away from the acute setting to the community setting. And what we need to do now is make sure that these new pathways, whether they're virtual clinics or otherwise, have strong clinical governance, are themselves audited, are themselves demonstrated to be safe and effective and meet patient satisfaction and expectations. I mean, of course, we need to support our healthcare workers in the delivery of these new forms of care. The third element was how important data, or useful information rather than using the term data, enables healthcare services. And we needed that at speed and in real time throughout the pandemic. We needed real clinical and operational data. And again, to pay tribute to the intensive care community and their own audit, is we were able to, because of their work and their proposals and the work of that audit, we were able to have a bird's eye view of capacity throughout all intensive care units in Ireland. We were able to know who had COVID within our intensive care units. We were able to know who was being provided with enhanced care outside intensive care units. We were able to break down those intensive care units as to whether they were vaccinated or not, and even whether they were boosted or not. And this is only through that data enabling resource that was and the work of our colleagues in intensive care that we were able to have such an accurate feel and assessment of the capacity of intensive care throughout the pandemic. Next slide, please. Brian has already alluded to our own National Centre for Clinical Audit. This followed on a report I commissioned when I came in this office a number of years ago. And I suppose what we saw was that the Noca, which is an independent entity and works developed very close collaborative relationships with the HSE, that we needed a more formalised governance as to how the HSE would have education and training in audit, would in itself identify areas of weakness or concern that would perhaps lead to commissioning of audit, and would of course allow those reports from Noca to land within the HSE, so that we could through one structure and one engagement between operations, clinical and Noca, decide how we would land the recommendations and make sure they were followed through. So this follows through, as I said in this report of 2019, and is one of the core purposes of this centre is for implementing the reports from Noca and work with Noca in making sure that takes place. And it's in addition, it is an important part of this office is a strengthened clinical audit throughout the organisation, and that Paul shall mention shortly. Education includes education and training. Next slide, please. And this an outline of the current governance structure. With this, we have a steering group for clinical audit, overseeing the work of this National Centre of Clinical Audit, which links national clinical audit providers, including Noca, and other areas such as the RCPI and audits that are carried out elsewhere, and links them to the HSE. Next slide, please. The work of this, our national centre, includes governance of clinical audit, local governance for clinical audit, as I mentioned, education and training, provision of resources for audit education, and laterally legislative changes. Obviously, we're taking a keen interest in the passage of the patient safety bill through the Dáil, as one of the core functions of this bill is to protect clinical audit activity. So I outline here some of the key outcomes of this new centre, which comes within my office. The work streams, a website, prioritization of audit, and Brian has mentioned some new areas of interest, which include community healthcare. Perhaps there's a slight slant towards hospital-provided healthcare in audits to date, and with a left shift with the principles of stauncher care, bringing healthcare, particularly for chronic disease and older people in the community, and also, as I mentioned, the growth of virtual clinics and virtual medicine and e-health. There may be a need for us to focus on these new forms of care to ensure that they're delivering high quality care, focus on the needs of patients. Next slide, please. An important part of this office will be training and education. Clinical audit e-learning programme will go live in 8th April via HC Land, and a range of clinical audit training programmes are commencing at May the 22nd, May of this year. Next slide, please. Further information available on the NCA website, which is there at the bottom, and you'll find the National Centre for Clinical Audit, as I said, which a strong partner with Noca, and I look forward to working with Colette and Brian in the coming years to make sure we embed that relationship, and that everybody benefits as a result, and patient care is enhanced as a result. Next slide, please. Just a few points. Clinical Audit Awareness Week, 30th of June in the UK, 17th of June, opportunity for our own office to link in with UK networks, and is a campaign to promote and celebrate the benefits and impact of clinical audit and QI work in healthcare, and it's a collaborative exercise. And work is underway to rewrite the clinical audit a practical guide. Important part of our work is to enhance capability throughout the services for clinical audit. Next slide, please. So thank you very much, Brian, and to colleagues here for your time and for your work, and congratulations on your first 10 years, and looking forward to many more.
Thanks, Colin. And I think it's one of the themes we're hearing is that idea of partnership between patients, between health service providers and healthcare professionals, and wider society is really key to success. I'm just conscious of timeline, so I'd like to thank Dr. Colin Henry for his address, and I'm going to and his update, and I'm going to just roll into our next presentation, which is Dr. Ronan Margie, who's the clinical lead for the Irish Heart Attack Audit. Ronan originally hails from Letterkenny in County Donegal, and is now based in the Mater Private Hospital in Cork, and serves as the lead cardiologist and the clinical director there. He has had, in summary, a stellar postgraduate career, training in some of literally the world's best centres in the US, and we're very fortunate to have him here. He has an interest in epidemiology and the use of data, and has a master's degree from the LSE, the London School of Economics, in this area and has been serving as our national clinical lead for the Irish Heart Attack Audit. And Ronan and his colleague Michael will introduce in a minute, are going to present the launch of the Irish Heart Attack Audit and the first report. So without much further ado, Ronan, I'll hand over to you. Thank you.
Thank you, Brian, and thank you for the kind introduction. It's my pleasure this morning to present the results of the Irish Heart Attack Audit. And this is the results of ST segment elevation myocardial infarctions in Ireland from January 2017 to January 2020. We know that there are about 6,000 heart attacks every year in Ireland, and to briefly categorize them, there are two broad categories of heart attack. There's STEMI heart attack and non-STEMI heart attack, and STEMI heart attack accounts for about 1,500 heart attacks a year. And with STEMI heart attack, there's occlusion of one of the three main arteries that carry blood to the heart, and blood flow is cut off, and time is heart muscle, so it's really critically important, emergently important, that blood flow is restored to the heart muscle to prevent complications such as heart failure, but also death. And internationally, treatment for STEMI heart attack has been revolutionized over the last 15 years, and really the best treatment with the highest success rate and the lowest complications is what's called primary PCI, or primary angioplasty, where a cardiologist passes a tube, usually from the wrist, inside the circulation to the heart, and then threads a wire along the blood vessel past the blockage, and a balloon is inflated to reopen blood flow to the heart and stop the heart attack. And that's been endorsed internationally as best treatment. And there's a treatment target to try and achieve that from the time the patient seeks help to the time the artery is reopened of 120 minutes. Now, within that, there's 90 minutes allowed to get the patient to a PCI center or a cath lab where the procedure can be performed. And then when the patient gets there, there's 30 minutes to allow you to get inside and open up the artery. And those are broadly endorsed both in North America and in Europe across several different countries as the best treatment practice for heart attack. So in 2012, a model of care for STEMI treatment in the Republic of Ireland was introduced. And the sole purpose of that really was to try and improve the geographic access around the country to primary PCI and the timeliness of that primary PCI service. There are also a number of secondary aims to reduce the average length of stay, to improve prevention care, so to improve smoking cessation, to improve access to cardiac rehabilitation, and to improve the prescription of appropriate medication that reduce the risk of a future heart attack over time. And a key component of that was to introduce an audit program to really feed back that information to the hospitals performing this intervention and allow them to benchmark against the national standard and what was happening internationally. So as part of that audit function, a data set known as Heartbeat data set was developed. That was based at the time on a review of international best practice from the UK Myocardial Infarction National Audit Project, the American College of Cardiology, Get With The Guidelines, STEMI treatment guidelines, the European Society of Cardiology, STEMI treatment guidelines, and other international registries. And it used standard variable definitions defined at EU level for cardiovascular outcomes research. And a suite of 63 variables, now up to 66 variables now in the current iteration until January of this year, are recorded on patients who are treated with STEMI. And that's a mixture of demographic data, data around the timeliness of how the patient has accessed care, data around the quality of the reperfusion treatment they've received, and then outcome measures. And that data was collected from the 9 sites that participated in primary PCI. And since January of last year, we've added data collection from Waterford as well. So now all sites in the Republic of Ireland that perform primary PCI as part of the National PCI Service contribute data to the STEMI audit. And in 2020, that data set migrated into Noca. So in terms of key performance indicators for STEMI that were defined at the time, the two key performance indicators were really the proportion of patients who had a STEMI heart attack that were offered reperfusion treatment. And then of those people who were offered reperfusion, what proportion got timely PCI? Timely PCI defined as that international best practice first medical contact to balloon inflation of 120 minutes. There are also a number of other secondary KPIs that were defined in the heartbeat audit originally. The first two, as I mentioned, were the sort of key reperfusion priorities. Was the service doing what we wanted it to do? Were we getting more coverage of people with STEMI across the country, and were they getting reperfused in timely fashion? But we also wanted to look at median length of stay and the number of bed days used. We wanted to look at access to cardiac rehab. We wanted to look at access to smoking cessation for patients who smoke. And we wanted to see were patients discharged on appropriate medicines that help reduce the risk of future heart attack. So really, as I mentioned at the start of the standard care pathway in 2012, the audit developed, and the first report of the audit was produced in 2015, which really gave us a point estimate of how the service was doing in 2014. And then a second point estimate of how the service was performing in 2016 was published in 2017. And there were some general trends that had already begun to emerge between 2014 and 2016 that are commented on in that report. And then the data set was in hibernation, really. The data was being collected in the clinical sites, but wasn't really being analysed or fed back to the PCI sites. And Noca inherited this data set in 2020, and it became rebranded and relaunched as the Heart Attack Audit. And of course, our aspiration is not only will we provide more timely feedback of the analysis of outcomes for STEMI care to the hospitals, hopefully on a quarterly basis going forward via an electronic dashboard, but we'll also expand the audit to include those other heart attacks, the non-STEMI heart attacks, as well over time. So this graphic or factoid shows the key findings from our report 2017 to 2020. It's quite a busy slide, so I'll go through each of the different aspects now individually. So there are about 5,600 STEMIs in that time period that were confirmed. Of those, about 500 patients didn't proceed to reperfusion, and the commonest reason why that was that the patient had just simply presented too late and there was no benefit to reperfusion therapy. Patients predominantly presenting with STEMI, it was their first manifestation of coronary heart disease in 3/4. Only a quarter had a history of previous cardiovascular disease or vascular disease or a major comorbidity diagnosis like chronic lung disease or chronic kidney disease. Like the experience internationally, STEMI heart attack seems to affect males more than females, whereas non-STEMIs, the gender balance seems to be reversed. So 78% of patients with STEMI were male. The median age of heart attack was 63. Men experience heart attacks slightly younger than females. So the median age of men was 61 and females it was 69. Also, the age spectrum at which heart attack peaks is different between the genders. So 56% of males with STEMI were aged between 40 and 65 years. In females, a quarter were actually aged over 80. And not only were females slightly older, but they also had higher rates of comorbidity or multimorbidity, I guess, which is a challenge to people like Colm in the health service every day, leading to longer lengths of stay and more complications. So they had higher rates of stroke, chronic kidney disease, and lung disease. In terms of risk profile, well, I've already outlined the age and gender differences, but 3/4 of patients had more than one cardiovascular risk factor, so quite a risky population. 43% had hypertension, 43% had hyperlipidemia, and I mentioned earlier that about a fifth or a quarter had previous cardiovascular or coronary heart disease. Diabetes was reported at 14%. Now, we think that that's likely a systematic underreporting because patients spend a very short period of time in a PCI centre where the data is collected, and they're often repatriated back to a Model 3 or a non-PCI hospital for the rest of their episode of care. So they may spend a very short time in a PCI hospital, not have a formal diagnosis of diabetes made there, but then have a subsequent diagnosis of diabetes. And because we have issues with tracking data between sites, that may result in underestimation of diabetes. Probably the most stark risk factor difference in people with STEMI is the smoking rate. So 34% of the patients present with STEMI were active smokers at the time of their heart attack. Now, to put that in context, the population incidence of smoking at the moment is 17% in adults. So it's almost twice the population background incidence of smoking. So there's a disproportionate amount of smoking in people with STEMI. And not only is smoking higher in people with STEMI, but smoking seems to drive heart attack at a younger age. So 64% of STEMIs in people aged under 40 were active smokers. And we still have a problem with recalcitrant or relapse smokers, with 26% of patients with a documented previous heart attack being active or relapse smokers on their presentation with a second heart attack event. And this is really a key take-home message from an epidemiology or prevention point of view. Smoking causes really premature cardiovascular disease and premature heart attack. And on average, just a simple rule of thumb to take away from the presentation, on average, smoking causes heart attack 10 years earlier. So males who smoke had a heart attack at a median age of 56 compared to 65 in non-smokers. And in females, the difference was even more stark. It was 60 years in female smokers versus 76 years in non-smokers. But what about the real crux of the reperfusion service? How did we do in terms of patients accessing the care and receiving timely reperfusion? Well, this is a mantra I want to use over the next couple of slides. The key with reperfusion is getting the right patient to the right location to receive the right treatment at the right time. So only 37% of the patients with STEMI actually contacted the emergency services or sought help within an hour of their symptoms starting. And this is too low. I said at the outset that time is heart muscle. So any delay at this point leads to worse outcomes. And then when the patients contact the emergency services, about 60% are brought directly by an ambulance to a PCI centre. And we'd like that number to be as high as possible, because arriving at a PCI centre means that they can access reperfusion in a more timely fashion. About 10% of patients self-present or walk into a PCI centre. So if you put those together, about 70% of the population directly access a PCI centre. And that's an improvement compared to 2016, and we'd like to keep that trend going. However, there's still a rump of about 28% of patients who present to a non-PCI centre first, and these patients then need a hospital-to-hospital transfer. And those of us that work in the health service know that whenever we have to move patients from one hospital to another, it tends to introduce delay. So if we can get the right patient, recognizing their symptoms promptly, having a pre-hospital diagnosis of STEMI, getting brought directly to a PCI centre, they can get the right treatment in the right location. In terms of timeliness, only 67% of the overall cohort of STEMI patients receive what we would define as timely reperfusion. And the median time from first medical contact to balloon inflation is 98 minutes. So remember, I said the international best practice target is 120 minutes. So we do okay in terms of the 120-minute target, but not enough people meet that target. And there's a trend to suggest that that's a slight decline compared to 2016. However, how people access the service really delineates the timeliness of the reperfusion. So for those patients that come directly to a PCI centre, 84% receive timely reperfusion, and they have a much faster reperfusion time with a median first medical contact to balloon time of 84 minutes. For those patients that end up being transferred from one hospital to another, only 22% receive timely reperfusion, and the median first medical contact to balloon inflation is 155 minutes. And our data would suggest that that's declined compared to 2016. And then only 39% of patients receive timely thrombolysis. So thrombolysis is an older treatment for heart attack where people are given clot-busting medicine to dissolve the clot that's blocked the artery. And if a patient can't be transferred to receive a primary PCI within that 90-minute window that I said for transporting the patient, they should receive timely thrombolysis. So in our rush to expand and standardize primary PCI, one of our unintended consequences seems to have been a delay in providing thrombolysis when patients very clearly can't be transferred in a timely fashion. And this is something that we'd really like to feed back to the individual PCI sites and their referring hospitals to work on as an area for improvement. Again, if we get the right patient in the right location at the right time, receiving the right treatment. What about the quality of the PCI care that patients receive in the PCI centre? Well, this, I think, I'm biased, I do these procedures. I think the care is excellent. So an international best practice target is that patients bypass the emergency room and go directly into the cath lab. That happens in 4/5 of our patients, and that's improved, and it's continued to improve through the pandemic. In the pandemic, it was up to 86%. 93% of patients receive their procedure from a radial artery access. That's a big improvement compared to 2016. That's international best practice again. Radial artery access is associated with much lower complication rates, much less bleeding, and that translates into better survival and less death. And then when patients reach a primary PCI centre, from the time they arrive to the time the doctor has opened the artery with the balloon, the median time is 27 minutes. And remember, I said that the goal internationally is that that's achieved within 30 minutes. So in terms of the quality of what's delivered in an emergency, patients being blue lighted into the cath lab, registered by the administration staff urgently, put on the table by the nursing staff, connected up to ECG monitors. Doctors are putting a tube in the artery at the wrist to perform the procedure. They're getting a wire down the vessel, balloon up. All of that happens really quickly and to a really high standard. So what about outcomes then? So I'm going to start a conversation with outcomes by mentioning data quality. One of the things that happened from 2017 when the last analysis of this data was presented was that the data was collected, but there was very little completion of the audit cycle with feeding back the data. There was no data analysis, there was no report. And so the quality of the data that was entered into the data set, the database, and the completeness of that declined over time. And this particularly affected the quality of the outcome data that we collected. And therefore, we felt it was unfair and perhaps not particularly statistically, scientifically sound to do any risk adjustment modeling, multivariate analysis, or to do any hospital by hospital comparison. But if people are listening in the PCI sites today, that will be in our report next year. We're going to begin the process of benchmarking sites against the national average and trying to drill down into unexplained variation on a site-by-site basis. So the unadjusted crude in-hospital mortality rate was 5% in this cohort of STEMI patients. That's really good. Internationally, across multiple different registries, the mortality rate reported in hospital for STEMI would range from 4 to 6%. So it suggests that we're sort of right bang in the middle of where we would expect for mortality with STEMI in Ireland. But it is important to highlight the impact that timely reperfusion makes on survival. And in patients who have timely reperfusion under that 120-minute window, their mortality rate was 2.8% versus a mortality rate of 5.2% in patients where there was a delay in reperfusion. So the timeliness of reperfusion results in an improvement in survival, and delay results in almost a doubling of mortality. There also is an association or an interaction between age and mortality. Again, in older persons over 75, the crude unadjusted mortality rate for STEMI was 12% versus 3% in persons under 65. The complication rates from the procedure, emergency procedures, 24/7, 365 days of the year, and patients being brought in a rapid fashion, very limited information available about their background. Complication rates are really low, 1% stroke rate, 1% major bleeding rate. This is on par with the best results that we see internationally. Median length of stay is 4 days. Now, I caveat that by saying that we truncate the follow-up for patients that are repatriated, so we may be systematically underestimating length of stay, and the patients that stay in primary PCI centres tend to be sicker heart attacks, which by their nature may have longer lengths of stay and more complications. In terms of secondary care or secondary prevention care, I think the message here, in the interest of time, is we could do a better job. We set ourselves pretty high targets of more than 90% for all of these metrics, and we're below those 90% targets across the board. Only 85% of active smokers get smoking cessation counselling. Only 71% of patients are referred to a cardiac rehab program. And where it's recorded in the data set, only 76% of patients get discharged with a complete secondary prevention bundle of medication. So if I was to sort of try and simplify the trend that we saw in the Noca report compared to the last report from 2016, what sort of trends do we see? Well, we see that overall there's been a slight decline in timeliness of reperfusion, particularly for patients that are transferred from non-PCI sites. And this is a real clear target for intervention and improvement. However, in patients who are directly admitted to PCI sites, the timeliness of reperfusion is really good. And overall, the total proportion of patients that are directly admitted to a PCI centre is increasing. And that's a trend we'd like to continue. If we can get patients to the right centre at the right time, they get the right treatment and they have a better outcome. ED bypass is an important development that helps save time. Radial access is an important development that helps to prevent complications. And we can see very clearly that the timeliness of reperfusion has a direct impact on mortality after Stemi. And so therefore, we really need to make sure we focus on continuing to improve the timeliness of reperfusion. So from this, there were a number of recommendations which we made targeted both firstly to the audit itself, and then secondly to the wider health service. And within the recommendations to the wider health service, there are a number of recommendations around that specific group of patients that are transferred between hospitals. There's recommendations around trying to direct patients to recognize symptoms and get a pre-hospital diagnosis of Stemi so they can be brought directly to PCI centres and cutting out the delay. And there's risk factor recommendations. So just to roll through these very quickly, in terms of patients that are transferred, we want to standardize data collection in these patients so we can figure out where the delay in reperfusion is occurring and try and understand that delay. So we've worked in collaboration with the National Ambulance Service and the Acute Medicine Programme, and there's now a standardized national inter-hospital transfer form, which we've contributed some variables to that will allow us to track where these delays in reperfusion occur, and we'll have that in our report, hopefully from 2023. We want to improve the quality of the data we actually collect in Heartbeat, so we've developed a standardized verification and validation process. We've re-educated our data collectors across our 10 PCI sites. We've done a lot of workshops with them, so we make sure people are collecting the information in the same fashion across the hospital network. And we're going to feed back that information on a quarterly basis. So one of the audit dashboard items that we're going to include is the quality or the completeness of the follow-up data that your site has recorded. Of course, we're hamstrung, and this is a call to the funders to really make sure they resource data collection adequately, especially if we're going to scale up to non-STEMI, which will involve us expanding from 10 clinical sites to 36 clinical sites and tracking patients between multiple hospitals and into the private sector for non-STEMI care. And really, as other speakers have highlighted, an individual or unique health identifier would really facilitate that tracking. We want to also confirm mortality. Death after heart attack is a really important outcome measure and a really important indicator of the quality of care the patient receives. And really, we find it quite hard in the absence of a universal health indicator at tracking patients through our hospital system and back into primary care. And we have early repatriation of patients from primary care from primary PCI sites. So we may miss mortality, and we'd really like to see the introduction of the ability to confirm death registration data with the Central Statistics Office in a fashion similar to the National Cancer Registry.
Ronan, I'll just ask you to just be mindful of time. Thank you.
Yeah, sure. I'll try and sum up in 2 minutes. So a lot of these recommendations are linked now from this on. So I'll skip forward to recommendation 5. We wanted the hospital sites to really focus on improving the timeliness of reperfusion for patients that are transferred. And that's going to involve them taking the information from our audit now and developing their own local quality initiatives to try and identify the barriers that result in delayed diagnosis and timely transfer of STEMI patients. And where it's not possible, physically not possible to transfer patients, that they have appropriate thrombolysis protocols to so-called drip and ship the patient. And some of the variation in transfer patients can't be explained by geography alone or distance alone. So there's quite a variation in practice here, and we really need to understand where this delay comes from. So with that in mind, we've recommended introducing a KPI of a so-called door-in, door-out time. And that's endorsed at European level, and it suggests a patient should exit a non-PCI hospital and finish their journey to a PCI hospital within 30 minutes of arriving at the non-PCI hospital. And we're going to start tracking that door-in, door-out time from this year to try and really understand these delays. We want to address risk factors. So the smoking rate in the STEMI population is quite stark. And as I said, it drives heart attack at a younger age, and it's a real clear target for health promotion and prevention. Individual risk factor control still remains quite important, and we know we do a reasonably poor job of not only identifying risk factors, but optimally treating them. And this is a target for the chronic disease management programs. And then lastly, what I hope I clearly showed in the data was if we shunt patients directly to PCI centres by diagnosing them pre-hospital with an ECG and away from self-referring to a local emergency room, we get the right patient to the right location for the right treatment in a more timely fashion. And so if we could change the public behaviour to recognise symptoms and to activate the emergency service so they can get a pre-hospital ECG diagnosis of STEMI, then over time, we would hope to see that the number of patients directly admitted to PCI centres will rise and the numbers that need to be transferred between hospital will decline. I've already mentioned a lot of the audit developments, but just a final word, our dashboard is ready for launching later this year, and a lot of these quality metrics that I've presented today on reperfusion will be fed back on a live dashboard quarterly to each of the PCI sites, along with some dashboard information on the quality of the data that they're collecting. And we hope that this will become an engine to drive local quality improvement. Thanks for your time, and sorry for running over.
Thanks, Ronan. A super presentation, and I think it's heartening for us all to see the data there to allow us to see the room for improvement. I'm just going to lead into our next presentation, which is associated with our patient representative on the Irish Heart Attack Audit. It's Michael Madigan. Michael is married to clinical nurse manager Kate for 25 years, and they have 2 children, Daniel and Grace. He was born in New York before returning to Ireland with his parents at a young age, and trained as a nurse in the UK and has worked in Greece and Germany. Michael worked as a clinical nurse manager in the mental health services in the NHS and HSE before retiring in 2018 due to heart failure following a heart attack in 2016. Since retiring, he has dedicated himself to spending more time with his family and aptly staying out of hospital. Michael is a member of the National Heart Failure Patient Panel who support the advocacy role of the Irish Heart Foundation. He enjoys being involved in local community projects, keeping fit and travelling, and Michael is attending today and has a pre-recorded presentation. Thank you.
Good morning, everyone, and welcome to today's conference. I hope you all enjoy it. My name is Michael Madigan, and I had a serious heart attack approximately 5 years ago, and I'm going to share my experiences of that with you today. I'm going to be reading from some notes. It was a normal Friday morning, and I was at home in Cavan having breakfast with our kids in the kitchen, and I had previously been investigated for heart problems approximately 5 years before due to having a positive family history. My father died young, and I had 2 uncles who also had heart problems. But I thought at the time that I was in better than average general health. I was about 11 stone. I was eating well, walking every day, keeping fit. And Then I felt this sharp pain in my chest on this Friday morning in October 2016. I had pins and needles in both arms and I started sweating, which I shouldn't have been on that day. My wife was on her way home from a night shift at at Cavan General Hospital where she works, and our son had just gone out to catch the school bus. Our daughter, who was 10 at the time, was still having breakfast. I called 999 immediately because my symptoms were so obvious and I was very anxious. I knew, I was 99% certain I was having a heart attack. I spoke to the 999 control while waiting for the ambulance, and I prepared myself, got my jacket, my phone charger, my wallet, because I knew I was going somewhere that morning. About 15 minutes later, 3 paramedics arrived with the ambulance, and when they first saw me, they were joking about football. Our area had recently won a championship, and they were asking me about that, and asked me if I would go to Cavan General with them to see what was going on, to see if I needed help. And my wife arrived home approximately that time, and they put a 12-lead ECG on me. And at that time, the whole atmosphere really changed because they could see that I was having a serious heart attack. They explained that I was having a Stemi to us and administered clot-busting medication and morphine. And I could hear them on the radio to the air ambulance in Athlone and to the Mater Hospital. Within an hour of calling 999, I was in a helicopter at Arva football pitch en route to the Mater Hospital. It was my first time in a helicopter, but I felt very safe and very, very looked after. Approximately 20 minutes later, we landed in a park close to the Mater Hospital, and I was taken by another ambulance to the Mater. I was rushed into the cath lab as an emergency. There was another man waiting to go in for a routine procedure, and he was pushed aside because I had to get in there straight away because it was an emergency. The doctors and nurses asked me when I got in if I was a smoker. Every one of them, I think, who approached me asked me if I was a smoker because I was 48 and I didn't fit the profile for somebody who to have a heart attack unless I had been a smoker. When I told them I wasn't, I'm not sure if they believed me. I was 100% blocked on one side of my heart and 90% on the other, and I had 2 stents fitted once the clots were removed. And by lunchtime, I was in recovery, having coffee and toast and on my phone when my brother visited me. He works and lives locally, and he was surprised that I was awake and alert and on my phone. I was returned to Cavan General Hospital to the coronary care unit that evening and spent a week in coronary care and was discharged home after a week. I remember my consultant asked my wife to come in before I was discharged, and he reassured, said, "Mrs. Madigan, Michael's going to be fine. Within a few weeks, he'll be back to doing the housework and there'll be no stopping him." And she couldn't believe it. He said I would be doing the hoovering, the laundry, basically everything around the house. And she was surprised because I hadn't done much of that before. On discharge, I was followed up by my GP, the outpatients clinic at Cavan General, and the heart failure nurses at Cavan General. I was also referred for cardiac rehab and returned to work after approximately 6 months. The cardiac rehab was quite helpful, I must admit, but it was strange as a 48-year-old being in the rehab sessions with men who were mostly in their late 60s, 70s, and some in their 80s. But it was beneficial. I was well then, after returning to work, and then exactly 1 year to the day, on the day before my 49th birthday, which was exactly a year to the day after my heart attack, I had complications when I was at work. I felt unwell, my hands were numb, I couldn't feel my fingers. I checked my pulse and it had dropped to, I think it was 36 beats per minute. I phoned my line manager, whose name is also Michael, and I said, Michael, I'm not feeling well. I can hardly feel my fingers. He said, Michael, take yourself to the on-call doctor and see what's going on, which I did. And I was then readmitted to Cavan General Hospital, and I remained there for 25 days because they identified some irregular rhythms, and I was referred for an ICD, an implantable cardioverter defibrillator at the Mater Hospital, but it wasn't going to be immediately, so I had to wait a number of weeks in Cavan until the Mater were ready to implant my defibrillator. So that happened in November of 2017 at the Mater Hospital, and I have been attending the Mater Heart Failure Clinic every November since then, where I receive, it's like a one-stop shop. I go there, I get my observations done, I get an ECG done, an echo, heart echo. Most years, I go to the ICD clinic also at the Mater and have my defibrillator checked, and I have I see my consultant. I also continue to have annual outpatient appointments with my consultant at Cavan General, and I see the heart failure nurses in the heart failure clinic at Cavan General on a need-to basis. If my medication's been changed, I go there and they supervise that. I also continue to get follow-up from my GP, and my pharmacist has also been very supportive, and you don't realize how important your pharmacist is until you are on 6 or more tablets twice a day, and yeah, you really become friendly with your local pharmacy. Since my heart attack, I have made good progress. I officially retired in 2018 because of the heart failure. I was given an option to retire. I've been generally good health. I've kept myself very active since I've retired because I have the time. I've had no admissions to hospital since 2017, but I have occasional attendances at casualty due to nosebleed mostly, as well as getting great support from the HSE. I also have excellent support from the Irish Heart Foundation, who I became familiar with more so after I had the heart attack, and then since I've been retired, I've become involved with them more, and I'm now part of their National Heart Failure Patients Panel, which I enjoy. I'd like to welcome the publication of the Irish Heart Attack Audit National Report today, particularly the summary report, which makes the data more accessible and transparent to the public. I'd like to go back briefly to say that the most important messages that I would like to relay are that when I was having my heart attack, it's so important to phone 999 immediately. As soon as you think you're having a heart attack or you might be having a heart attack, make that call, because it's not the end of the world. If you're not having a heart attack, it's great because you're not having a heart attack, but it's no problem. It's best to make the call and be safe, because if you're having a heart attack, you need to get to the right place at the right time, which is a cath lab, and not every hospital has cath lab. And the decision that I made on that day to call 99 was a good one, and the decision of the paramedics to transfer me to the Mater Hospital so promptly was decision too, and I'm very grateful to them and everyone else who's been involved in my care. And I'd like to thank you all very much for listening to my story. Thank you.
Thanks, Michael. I think that, thank you for sharing such personal experience, but actually showing us what is behind our clinical audits and the individuals and their experiences, and a very clear message from Michael, who's also had some media engagements this morning, that if you have a serious health issue, you need to present to care quickly. So I'd like to thank Michael for that. We will take questions, and I know there's, just to remind, you can ask questions through the portal on the right hand side on the tab, and we will deal with the questions as part of our questions and answers session later. We're just a little behind time. So, and I'd like to acknowledge both Michael and Dr. Ronan Margie and many of the others who are involved on their governance group, and Dr. Sean Fleming and Joe McCormick, the audit lead, and also many others, and those that collect data and facilitate the use of data in hospitals and patients who contributed to this audit, and say well done to them. It's the first audit, I believe, is always the most difficult. Now, without much further ado, I might move on swiftly. So this is, as I mentioned as part of my introduction, our Noca Quality Improvement Champion Awards for 2022. So our first, we have 3 presentations. Our first presentation is by Ms. Shiji, who's a stroke clinical nurse specialist in University Hospital Limerick. And Shiji will be presenting on Stroke HIPE Data Reconciliation Project. Thank you. Just CG connected there.
Good morning.
Good morning, CG. We can hear and see you, so I'll let you share screen there. Thank you.
All right, yeah. Good morning, everyone. As a nursing professional, we all had a question always: why should we collect data on the clinical area rather than we could spend more time on the patient care? I totally understand after doing this project how important the data collection is after doing this QIP. As Mr. Colin Henry mentioned on his talk, that better data will lead to better patient care. So I'll move on to the slide. Next slide. Can I get the next slide, or do I need to? Yeah, the driver for this quality improvement project.
You're not screen sharing there. If you could just share your slides, please.
Okay, sorry. Just a second, I think I'm having trouble with this. Slideshow. Can you see the slides?
No, we're just seeing we're not seeing your shared screen, CG.
Share screen.
Shiji, if you wish, I can share them from here.
Please, yes, thank you.
That's super. Thanks, Greg. Thanks for participants for bearing with us. You can go ahead, CG, and just say next slide. Thank you.
Okay, yeah, thank you. Next slide, please. The introduction. The driver for this quality improvement project was the identification of a data mismatch between University Hospital Limerick stroke register data and the HIPE stroke data. Hospitals with less than 80% coverage are not included in the national stroke audit. This was the main driver for us to do this QIP. Can I have the next slide, please? So in 2018, UHL Stroke Register portal had 366 patients and HIPE had entered only 211 patients on the data, so which was only 57% coverage. So inadequate representation of stroke admissions to AHL, negative reputational consequences, and obviously money follows patients. So next slide, please. So aim of this QIP to develop accuracy and clarity of the stroke data collection, to improve the standard of stroke care in UHL, and to ensure the data is an accurate representation of the volume of work of the stroke services in UHL. Objectives were to identify gaps and anomalies in coding of stroke data for HIPE, collaborate with all stakeholders, i.e. HIPE coders, stroke MDT, HPO, and Noca to understand the reason and agree actions and solutions. UHL stroke data to achieve 80% compliance between HIPE and stroke portal, and therefore be included in National Stroke Audit for 2019 and onwards to enable a fair comparison with other Irish stroke sites. Next slide. And the methods we used. Step 1, stroke CNS helped by data analysts. We compared 2018 HIPE data with stroke portal data collected by the stroke CNS, and we identified CNS staffing gaps. And it was 43% of stroke patients did not meet the Australian coding standards criteria to be HIPE coded with a principal diagnosis of stroke. A significant number of patients who transferred back to UHL post-thrombectomy or neurosurgery were coded correctly as surgical follow-up care as per the existing Australian coding standards at the time. However, these cases did not reflect the primary diagnosis of stroke. The principal diagnosis of stroke patients who sustained a fall at the time of stroke were often coded as falls as per the clinical documentation in line with Australian coding standards. At the time of national review, not all stroke patients' charts had been coded by HIPE. There was a 3 to 6 months coding backlog. Step 2, meeting with HIPE manager to identify potential challenges and problems. We found there was uncoded HIPE backlog, minimum of 3 to 6 months at the time, as I said earlier. Ambiguous documentation, variation in language used in clinical notes regarding diagnosis, which results in primary diagnosis other than stroke being coded. Action plan, we met with HIPE manager and reviewed correct HIPE coding for stroke. We met with data analyst, prepared a report comparing CNS inputted stroke portal data to HIPE data. We determined the reason for not coding and inaccurate coding. Reconciled HIPE data with stroke portal data, and we recoded HIPE strokes appropriately. We arranged a meeting with Noca to discuss training requirements for data entry. At the time, there was no national training for the nursing professional to enter the data. In the absence of training, training manual was provided by Noca. Self-directed training from training manual. We liaised with HIPE manager to arrange training for documentation and coding for the people who are documenting in the notes. Agreed quarterly meeting with HIPE manager and stroke CNS for collaborative support, review, and quality control. Next slide, please. And we achieved the results locally at UHL. Since 2019, UHL has been included in INS report. UHL now received the correct funding for stroke services provided. Patients who were transferred to an EVT centers or neurosurgery from UHL are reviewed, and now they are coded, included in the stroke data. Quarterly quality control meetings with key stakeholders involved in the QIP continue to monitor data complaints. Going forward, hospital will not lose any additional funding. National level, amendments with HPO, Noca, HIPE benefited not only UHL stroke service, but also other areas in acute hospitals. Discrepancies were raised with the HPO, who reviewed the coding standards, and the decision was taken that previous cases not coded with primary diagnosis of stroke could be recoded where relevant. These changes were applied to other services throughout the country. Financial benefits to UHL stroke service. Stroke CNS with the data analyst identified 15 stroke patients who had been coded with the unrevised Australian coding standards. HIPE coders recoded these 15 cases to primary diagnosis of stroke as per revised Australian coding standards. I have a sample slide here, which resulted in gain of €280,000 owed to UHL stroke services from HPO. This was in 2020. Next slide, please. Sustaining improvements. To sustain improvements, a number of strategies and actions have been implemented. The ongoing reconciliation of data is embedded into practice. There's a regular follow-up and review with HIPE manager and stroke CNS, and quarterly meetings with the data analysts to review the stroke data. Noca are now providing quarterly DVRs as an additional quality assurance check to identify data gaps and are actioned by stroke CNS in collaboration with HIPE. KPI, the stroke CNS input 100% of data to stroke portal within 2 weeks of patient discharge from UHL. The recommendations, it is recommended that there is an annual audit of the stroke CNS KPI target. The development of a standard operating procedure for stroke data collection, entry, and quality assurance monitoring is planned. To maintain high level of compliance and data accuracy, it is recommended that there is an ongoing collaboration between stakeholders, stroke service, HIPE, HPO, Noca, data analyst, and UHL senior management. It is also recommended that the process, findings, and learning from this QIP be disseminated, which will help raise the profile and reputation of the high-quality UHL stroke service. Thank you. If there's any questions, you can put it on the Q&A session, please. Thank you.
Thanks, Shiji, and thank you for your composure despite the technical gremlins. So I think really excellent case demonstrating the importance of fundamental examining your basic data and how that's best done at the source of data collection. So I'm just going to move swiftly on and to our next presenter, which is Siobhán Corcoran, who is the Orthopaedic Business Manager, University Hospital Waterford. And Siobhán is presenting on the UHW Fast Track Knee Pathway. And Siobhán, I'll let you share your screen there. Thank you.
Thanks, Brian. I think my slides have been shared. That's great. Thank you. So as Brian said, my name is Siobhán Corcoran and I work as the Orthopaedic Business Manager in University Hospital Waterford. But for the purpose of this project, I was working as a clinical specialist physiotherapist with the Orthopaedic department in UHW. I have a special interest in the management of knee osteoarthritis, and today I'd like to share my fast track knee pathway with you. Next slide, please. So we're all very familiar with the negative headlines in relation to orthopaedic and physiotherapy waiting lists and the challenge to provide continuity. I'll just go back one slide there if that's okay. Thank you. The challenge to provide continuity of care during the COVID-19 pandemic has further escalated the pressure on these nationally under-resourced services. So what the fast track knee pathway really aims to do is to create a more efficient pathway of care for those with chronic knee conditions who currently sit on these lengthy waiting lists. Next slide. So the first patient we're going to meet is Bríde. Bríde is from Kilkenny and she waited 3 years to see the orthopaedic surgeon in University Hospital Waterford, only to learn that she didn't actually require any orthopaedic intervention when she arrived for the consultation. She should have had her care provided by her local primary care physiotherapist when she initially presented to her GP. So when we did an internal audit of our service in 2019, we learned that Bríde represented 56% of knee referrals into the musculoskeletal triage service as part of the Orthopaedic Department at University Hospital Waterford. Next slide, please. So pop on one slide, lovely, thank you. So next we're going to meet Tom. So Tom is from Clonmel. Tom also waited 3 years to see the orthopaedic surgeon in University Hospital Waterford, but by the time he arrived, his mobility had deteriorated so badly that he was unable to have surgery and now requires a significant home care package due to his poor mobility. Next slide. So clearly Breda and Tom have very different needs, but both referrals arrived into the orthopaedic department in Waterford, and sometimes it is quite hard to distinguish from the material that's on a referral as to who's more urgently in need of care. Breda is one of similar hundreds of referrals that arrive into the busy orthopaedic station in Waterford every year, but clearly her and other patients similar to her should have had their care more locally provided in their primary care area. These referrals are clogging up the station, and patients like Tom are waiting longer and longer for the care that they really desperately require. Apart from a really poor patient experience, this is further escalating our increasing waiting lists. It represents poor value for money, and it's a waste of valuable clinical time and space. Next slide, please. My solution to this is the fast track knee pathway, where healthcare and community connect. The pathway centres around patients being referred to the right service for their needs, and it represents a fully integrated patient pathway of care from initial GP visit right through to orthopaedic surgery for those in need of orthopaedic intervention. Now, if we go back, let's look at Breda and Tom's journey and how that could have differed using the fast track knee pathway. Next slide, please. So on the right-hand side, if we look at the traditional referral pathway where the GP refers into the orthopaedic department in University Hospital Waterford, at the time the project started, there was an average wait of 3 to 4 years for patients. On the left-hand side, then the fast-track knee pathway, when it's utilised, both Tom and Breda are referred by their GP to their local primary care physiotherapist in the first incident. Looking at Breda, Breda attends for 4 visits to her physio. Her knee pain settles and she's happy to self-manage on discharge and is now back playing golf and has no further medical requirements. We anticipate that more than 50% of patients referred for physiotherapy will have a similar outcome to Breda. Looking at Tom's journey then, Tom attends for 6 appointments but is still continuing to struggle with his knee pain. At that point, his physiotherapist refers him into the orthopaedic department in Waterford via a rapid access knee clinic as part of the fast track knee pathway. Tom sees the orthopaedic surgeon within a few weeks and is now listed for a total knee replacement. As a result of the fast track pathway, Tom now still lives at home independently without a need for home care services, having successfully had his knee replacement. This is the fast track knee pathway in action, and it can facilitate a much more efficient process with up to 5 times quicker access to the orthopaedic surgeon than the traditional model of care. Next slide, please. The UHW Fast Track Knee Pathway receives launch care funding to undertake the project between October 2020 and December 2021. We invested the majority of our funding into recruiting frontline clinicians, predominantly primary care physiotherapists and dietitians. These clinicians work specifically with patients on these lengthy waiting lists with knee conditions, and often these patients were waiting up to 2 years for physiotherapy at the time of the project starting, often as a routine referral and not being high on the priority, so really not getting any care at all. A lot of this cohort of patients also never had access to a dietetic involvement, which was crucial in their management. So this launch care funding allowed us to really give a bespoke programme for patients with knee arthritis. We also invested in digital and telehealth infrastructure as the project was redesigned to be offered virtually during COVID-19, and going forward we very much envisage a hybrid programme involving in-person and telehealth care both for individuals and in a group setting. Next slide, please. So in terms of project results, we had lots of bumps in the road because the project started just as COVID hit, and we had to evolve very rapidly over the course of the pandemic. We removed 409 patients with knee arthritis from physiotherapy waiting lists in Waterford and Wexford during the project period, and we had 4 pilot sites across both counties. 9 patients successfully received intervention using the rapid access knee clinic during this period, and all were seen within 4 weeks of referral following completion of their physiotherapy course. Overall, there's been a 64% reduction in wait time to access an orthopaedic surgeon in University Hospital Waterford across the pilot sites in Waterford and Wexford. And in a site such as Enniscorthy, which reduced its physiotherapy waiting list down to 4 months, this was actually 5 times quicker than the traditional model of care. Next slide, please. As part of the project, we also developed an automated database, which was predominantly used in the community-based physiotherapy and dietetic services, where traditionally clinicians don't have access to patient management systems and tend to have less administrative support. So the database that we created generates automated letters in terms of appointment letters and discharge letters, but more importantly for us, it allowed much better data capture for the purpose of research and audit. It was linked to the outcome measures that were collected over the programme, and it developed real-time statistics which could be used and reported on a monthly basis. As the project now expands, it also serves as a central point for data collection as the pathway becomes more mainstreamed. Next slide, please. So using the data collected over the course of our project, we recently completed a health economic analysis based on the numbers of patients seen, the outcome measures, and all the other quality data that we collected on this database. And what we found was the fast track knee pathway is more cost effective than the traditional pathway. Now, for the purpose of the analysis, we put the traditional pathway as patients just sitting on waiting lists. So we were quite conservative in that we assumed that they had no other additional deterioration in their health or required any other medical care while they sat on the waiting list. So it was quite a conservative comparison. First of all, we conducted a cost utility analysis, and we looked at the effectiveness measured in QALYs, quality adjusted life measures. And the results of this cost utility analysis suggest that the pathway is highly cost effective. Further from this, then, we also looked at gold standard cost effectiveness analysis, and we found that the probability that the fast track knee pathway is cost effective is 68%, confirming the findings of the cost utility analysis. So overall, a very cost effective initiative. Next slide, please. The fast track knee pathway has been recently approved by Sláintecare to become mainstreamed in both Waterford and Wexford, and we are in the process of recruiting dedicated permanent physiotherapy and dietetic staff to be appointed in the coming months specifically for this cohort of knee osteoarthritis patients. The project has received excellent support from the Health Innovation Hub Ireland following our involvement in the Spark Ignite competition in 2020, and they are in constant contact with us to help keep our pathway visible and to help with the business aspect of this pathway. We were also delighted to be selected as a finalist in the Innovation for Service Delivery category in the 2021 Health Service Excellence Awards. Next slide. We have a very strong team of core health professionals and advisors working in collaboration on the fast track knee pathway with representation across both the acute and primary care services. I'd like to specifically mention Mr. Terence Murphy, consultant orthopaedic surgeon in University Hospital Waterford, who has played a lead role in providing clinical governance over the pathway as it becomes an integrated service across both services. Next slide, please. We feel that the power of the fast track knee pathway is its scalability and its reproducibility, mainly because the pathway itself is such a simple model. We are currently working with the National Clinical Programme for Orthopaedics and Rheumatology on a proposed template for the National MSK Lower Limb Pathway using the fast track knee pathway as model. The model of care can be further developed for other MSK conditions such as back pain or shoulder pain, and also other specialties, which has a large component of its care delivered at primary care level. And using our database, we now have a centralised system where we can collect this data and use it to develop further business plans and to prove the power of the pathway itself. The pathway itself is very much in line with Sláintecare vision of right care, right time, right location, and empower service users with a clear system for them to self-refer back into the community services to empower them to have supported long-term self-management of chronic conditions. And we really look forward to this pathway becoming more widespread throughout the country in the coming years. Next slide, please. Thank you for your time, and I'd be delighted to answer any questions in the Q&A later on, and I've also provided my email address there should anybody want to contact me directly about the initiative. Thank you.
Thanks, Siobhán, and again, a super presentation highlighting action, research and innovation. I'm just going to move on for the sake of time to our next presenter, Ms. Gráinne Sheehan, who's the tissue viability nurse in the Mater Misericordiae University Hospital. And Siobhán is presenting, or sorry, Gráinne rather is presenting on a high heel initiative. I look forward to that.
Good morning, everybody, and many thanks for the opportunity to talk to you today about our High Heel initiative. This initiative was specifically developed to prevent heel pressure ulcers in hip fracture patients in the Mater Hospital. Co-authoring this project today is Mary Mullen, our Advanced Nurse Practitioner in Orthogeriatrics, and Ruth Buckley, our Quality Manager. So some of us may be familiar with the Irish hip fracture standards. There are 7 in total. And today, for those purposes, those who aren't, you can see the slide there. I'm going to be focusing on standard 3. So the Irish hip fracture databases, it uses meaningful data to drive quality clinical improvements in fracture care across these 7 standards. They're a bundle of care, and when these standards are used together, they drive incremental patient improvements and patient outcomes. So the Hip Fracture Governance Committee in the Mater, it uses this data to monitor and review areas for improvement. The data is captured in real time, and it's appraised monthly by the Quality Manager and our Orthogeriatric Advanced Nurse Practitioner. It's then presented back to the local Hip Fracture Governance Committee. So standard 3 is that a patient doesn't develop a stage 2 pressure ulcer or above. As tissue viability nurses, we would say you do not want to develop any pressure damage at all. And if you improve standard 1, so you're admitted within 4 hours, or standard 2, you receive your surgery within 48 hours and your pain is well controlled, ideally that should lead to you not developing a pressure ulcer, which is standard 3. Worth noting, however, is that it's important that not all damage occurs in hospital, especially given this patient cohort, long lies, immobility. So it's important that we are able to distinguish what we control. The treatment and the damage may not change, but we can only focus on what we can control. So when we had a look at our data in 2020, we saw a concerning increase in post-operative patients developing heel pressure ulcers in particular. So a pressure ulcer is a localized injury to the skin and or underlying tissues, usually over a bony prominence as a result of pressure or pressure in combination with shear, also underneath a medical device as well. So pressure ulcers are associated with poor patient outcomes. They prolong the length of stay, immense pain and suffering, and they also have increasing monetary implications. I would say that heel pressure ulcers are often misunderstood, and I think sometimes clinicians, they don't understand that hip fracture patients are particularly vulnerable due to the immobility, but also if they have associated neuropathy with diabetes or if they have arterial disease as well. I always say there's 2 victims when a patient develops a pressure ulcer. There's the patient themselves, as I mentioned, the pain and the suffering, but also the staff. I often see the staff's face when they have to contract to say that the patient has sustained some pressure damage. Nobody comes to work for any harm to come to their patients, so that's really important to note. So the data told us a story. It told us that the patient-centered service that we had, it wasn't delivering, in that we felt we could do better. How do we do that? Well, we did that. Sorry, just going to change that slide. So how do we do that? So we created a sense of urgency, in particular to reduce pressure ulcers in the heel area, because that's where our problem was. So we used a PDSA cycle, which was Cotter's framework for change, and the tissue viability nurse was invited onto the local hip fracture governance committee. We had a focused subgroup with the orthogeriatric AMP, the tissue viability nurse and the clinical nurse manager on the orthopaedic ward. And the clinical nurse manager was also our tissue viability link nurse. We held regular progress review and update meetings. And at this point, we really focused on our skin document, which I'll talk about in the next slide. And from that came the evolution of the high heel intervention. Just a little bit on the background, pressure ulcer prevention is really at the forefront in the Mater Hospital. We had rolled out the HSE wound care guidelines in 2019, and particularly the chapter focusing on pressure ulcers. We had a HSE inspection, which highlighted areas that we were performing well in with underneath those HSE guidelines, but also areas for improvement as well. We also conducted hospital-wide pressure ulcer prevalence audit, which we had done for 3 years in a row. Also, we also had begun to conduct pressure ulcer investigations using the Part A form as part of the incident management framework. And I should say that while these were investigations, they were open disclosure, non-blame culture, and they were specifically aimed at why did the patient develop a pressure ulcer. What was really good that year in 2020 was we shared the learning from the investigations from the Part A forums, and it was really changing across the organisation to see the clinical nurse managers present, the case histories of patients that had developed pressure ulcers. The very first one was a patient that developed a heel pressure ulcer, an orthopaedic patient, and just to see them present at the Nursing Quality Forum, really the feedback we got was really excellent, and it really sort of created a culture that we could change and we could do better. We rolled out the skin chart, and I'll talk about that on the next slide. And we also had introduction of the quality care metrics in September 2021 on the orthopaedic unit. So that's it. So the skin chart that I've spoken about already, it's a 4-in-1 document, and the first page focuses on a structured skin and risk assessment. But for today, we'll focus on the skin bundle assessment. So the skin bundle assessment, it's a bundle of interventions. When combined together, they lead to better patient outcomes in terms of not developing a pressure ulcer. So that focuses on skin inspection, support surface, keep moving, nutrition, and incontinence as well. So if you focus on the support surface, so you'll focus on what sort of mattress the patient needs, what sort of cushion, and what sort of heel offloading device. So interestingly, mattresses do not prevent heel pressure ulcers. That's why we specifically had to look at heel offloading. The heel mnemonic you see on the right would be a typical way of how we would assess a patient or speak with a patient when we are assessing their heels. We would obviously introduce ourselves. We would say, hello, please, can I check your heels? A lot of our patients, they're hard of hearing, they have dementia. So yeah, really have to explain. You have to say, I have to remove your TEDs, and you have to do this twice a day. So hello, please, can I check your heels? You need to examine and check for signs of pressure damage. So erythema, heat, induration, bogginess. And then you're going to naturally elevate the post-operative hip fracture patient's heel on something. Generally speaking, it can be a pillow longitudinally, but not all patients tolerate a pillow. Some need an offloading device, and hence the high heel intervention became a simple air boot. It was a simple offloading boot, and heel suspension devices that float the heel are ideal for these patients that will not offload their heel on a pillow, because it avoids pressure to the Achilles area and it maintains knee flexion of 10 to 15%. So what was the effect of our high heel intervention? So as you can see, we noticed a significant improvement in the first 6 months of 2021. We started the intervention in November 2020. Although this benefit tapered off slightly in the second half of 2021, there's no statistical difference noted as controls have remained in place. And we know this because the acute care metrics launched in September 2021 to January 2022, and they've demonstrated a continuous improvement as well. I would like to acknowledge throughout, I suppose, 2021, staffing was an issue in terms of the orthopaedic unit became a COVID ward. The nursing staff worked tirelessly and really well, and at times it was part COVID ward and part orthopaedic unit. So not all nurses were essentially trained in orthopaedics as well. So as you can see from the SBC chart, that the boot was applied when necessary. It led to a reduction in the prevalence of heel pressure ulcers. So how did we establish this, and how did we, I suppose, get the high heel initiative going? Well, with MDT engagement. The multidisciplinary team approach was essential. Patients' early mobilization, so Standard 7 says that the patient must be mobilized day 1 post-operatively. All hip fracture patients have a routine dietetic review. So as part of the nutritional guidelines, we introduced snack bags in 2021. So that's 3 main meals and 2 snack bags. So I've already mentioned the ward tissue viability link nurse, the clinical nurse managers, but the staff nurses and the care assistants, they were absolutely pivotal because they were the ones at the bedside, doing the assessment of the heels, completing the skin document, they were the ones that ensured that the ordering of the offloading boot was there, that they put the heel offloading boot on and off the patient after they went to the loo. And this really, you know, it showed them that they could really foster a culture of change, and it was within their control as well. The tissue viability nurse, there's two of us, myself and Lisa Joyce. We maintained a clinical presence, and clinical leadership and visibility, it always brings change. We held regular meetings with the subgroup which evaluated our progress and the impact of the high heel intervention. And we just naturally expected a sustained reduction in prevalence due to these actions taken. But it was really important that we kept the energy going, and that, you know, we kept that sort of clinical visibility and leadership as well. It was really important that the staff felt that we all worked together. As I said, there was open disclosure, there was a non-blame culture. Yes, the graphic images always tell a story when, you know, you go back over the different investigations, but I really felt as tissue viability nurse that you had to be approachable so that staff could ask questions and you could allay any sort of worries that they had as well. So the patient experience, well, the patient is at the forefront of this high heel initiative, and motivating the patient to become an active participant in their care was really important, and the skin document, you know, focuses on that, in particular the open disclosure that I've mentioned as, already saying, look, we're here to examine your heel, we're going to offload your heel on a pillow, look, you don't seem to be able to keep your heel on a pillow, we're going to use a boot. And sometimes, you know, if the boot didn't work, we had to look at the cycle again and look at other ways to continuously improve. So we may need things like a silicone heel pad, or we may even need a wedge cushion. There is a draft algorithm of the heel products that we're using in the Mater Hospital that won't be released later in the year till we, I suppose, validate the other interventions that we're looking at in the present as well. And there is an audit underway on that too. We also had to develop strategies to overcome the COVID-related lack of visitors, because they're normally advocates for their relatives or for the patients. So we had to use visualization strategies such as walk towards the front door. You want to go home. You want to go home to your dog. So just little things like that. And just all along the way, we expected, you know, we tried to improve the patient experience and have better outcomes for our patients as well. A lot of our patients are vulnerable, and that was really important that we had to act as their advocate, as the nursing staff, as the care assistants, and all members of the MDT. So just looking at some cost benefit analysis, I've already mentioned that heel ulcers, they prolong hospitalisation and can lead to osteomyelitis and sepsis as well. Just some Irish data, treating one grade 4 stage 4 pressure ulcer can lead to can cost 119,000. Some UK data over on the right hand side, upwards of 36,000 to treat a stage 3 pressure ulcer that has osteomyelitis as a complication. In America, 11 billion is spent on pressure ulcer treatment. In the UK, 3 billion, and a lot of this accounts, 41% would be nursing time costs. Our high heel initiative was based on a simple heel offloading boot that cost €13, not including VAT, but we just bought in packs of 10, I suppose, which kept our costs down as well. So how do we sustain it? Well, the tissue viability service and nursing quality department, we advocated that mandatory tissue viability happened on nursing induction and for healthcare assistants as well. That skin document I've mentioned already, it was all nurses had to have education on that as well, and local education is ongoing. The link nurse continues to provide feedback on the intervention and on that. Also, the skin bundle assessment it happens every day, and it's a 7-day document. And as I've mentioned already, the heels must be inspected twice a day. So, just going forward, the Hip Fracture Governance Committee, it will continue to use our Noca data to drive quality improvements. And I suppose it's a continuous cycle that we're always driving quality improvement and always looking at other ways to improve. Thanks very much for having me. I should acknowledge all those identified in addressing this issue and those who have assisted with implementing the solution and preparing the report and the presentation today. Thanks very much.
Thanks, Gráinne, and super presentation and having immediate and definite impact for patients in terms, and you highlighted both the the impact to patients and the cost impact to the health system. Thank you. So I'm going to move on to our next speaker, Dr. Sally Lewis, who has been a supporter and has assisted Noca with other presentations in the past. Sally is the director of the Welsh Value in Health Centre and National Clinical Lead for Value-Based and Prudent Healthcare. Sally is a GP with frontline experience of primary care at its most challenging. She entered a career in medical management in 2011 and was appointed the Assistant Medical Director for Value-Based Care in the Annual Bevan University Health Board in 2014. And since 2018, Sally has been leading the National Value-Based Healthcare Programme in Wales, which is now part of the World Economic Forum's Global Coalition on Value-Based Healthcare. She's an honorary professor at the Swansea School of Medicine, and the title of Sally's talk is Knowledge is King. Thank you, Sally.
Thank you, Brian, for such a lovely introduction, and it's a pleasure to be here. I'll just sort my slides out. There we are. So we've just heard, I think, some beautiful examples of how data can drive not only quality improvement, but high value care and provide the evidence for changing models of care as well, which we know will be of key importance as we struggle to meet the changing needs of our population over the coming decades. So I'd like to try and draw that together into what might be a strategic approach for looking at clinical and also patient-generated data, and then a little bit about how we might have a systemic approach to using data and transforming it into usable information for all those who need it. And I'll use some examples from the work in Wales, which very much mirrors the aspirations for the work that Noca are doing. So one of the things that was interesting to me when I started moving into medical management roles was the focus that organisations had on financial and process data, and the amount of time and effort that was put into acquiring that data, presenting it and using it in relation to a real paucity of data on clinical outcomes and even less on patient relevant outcomes, quality of life and symptom burden of the individuals that we treat. So the consequences of not having parity of esteem with that data, as you know, are quite profound. And that's why I still really love this quote from Voltaire from 300 years or so ago, which is that doctors pour drugs of which they know little to cure diseases of which they know less into patients of whom they know nothing. Well, you know, hopefully evidence-based medicine has taken us on a little way over the last 300 years. But if you think about it, there's still something that rings true about that statement, because we are generating clinical pathways and treatments based on randomized controlled trials, perhaps as gold standard evidence. But of course, many of the patients to whom we extrapolate that evidence were patients who would have been excluded from those trials in the first place. So there are limitations to evidence-based medicine, and one of those is a lack of ongoing data around real-world clinical effectiveness and how we are meeting people's needs in real life. And of course, the other part of the evidence-based medicine equation, which is around patient preference and context. So where patients make choices which may veer away from the guideline in their own context, how do we understand their outcomes and what that means for our service? How do we understand clinical variation? We've been all striving for a long time to reduce unwarranted variation in care, and audit clearly really helps with that. But I would argue that we need to think about how we make that audit more live as well, so that it's not an annual report only, but that we have a process of looking at this data on an ongoing basis. Frequently, there's incomplete information or advice for people to make decisions about their care. So in an ideal world, we would be able to answer the question of, well, what happens if someone like me, you know, with my comorbidities, age, sex, and so on, if I make this decision about my healthcare, if I have this procedure, what outcome am I likely to have not just the average outcome that is likely. And also we need to get much better at reflecting a lot of information back to patients so that they can more effectively self-manage their conditions. And this is really important in chronic disease, isn't it? As we have a growing population who are living longer, but not necessarily healthier lives. So they are living a very long time, sometimes a decade or more with a chronic condition. And we need to be able to give them a lot more involvement in driving their own healthcare and their own better outcomes. And for that, we need good data and information to give back to patients. And also, we have no way of objectively knowing how people are getting on at home. So in my general practice, my way of tackling that is to follow up patients for my own risk management and my own satisfaction. And that's great, that's good care, but also there are a lot of unnecessary follow-ups in the system which don't necessarily benefit patients, maybe an inconvenience to them, use up capacity and so on. So how do we use data to understand how people are getting on at home and support new and more flexible models of care? So we need data to inform what we do across a whole pathway of care. And it's tempting if we work in a general practice or in a hospital to only consider the institution or the service in which we work. But really from a patient's point of view and from an organisational point of view, we need to understand where the gaps in service are. Where are we not meeting people's needs? So we need that whole system view from prevention and secondary prevention, making sure that we've got early accurate diagnosis of conditions, optimising interventions, paying the right attention to supportive treatment, and knowing when to flip from aggressive management into a palliative approach. So it's really important that we try and look up and out beyond our own service. And the data is absolutely critical in informing care at micro, meso, and macro levels. So what I mean by that is at a micro level in the consultation, what data and information do clinicians need at point of care to be able to support that therapeutic conversation? And similarly, what information do patients need to help in that shared decision-making process, perhaps, about their care? And then how do we do quality improvement across processes of care? But it's not just quality improvement, is it, in our own service? It's how do we provide the evidence for where we need to invest across the pathway, and how do we support choices in investment, choices in care setting, and so on. So it's very much how we use the data to take that broader view for high value care. And then finally, for population health, once we start to get larger aggregated data sets, what does that tell us about our strategies for improving health outcomes and sustainability of healthcare systems over the coming years? So this is the game we're all in. We're all trying to achieve outcomes for patients and achieve sustainability of healthcare systems. And there are patient factors and healthcare factors involved with that. So we need to be raising health literacy of the population of our countries and supporting healthy behaviours towards prevention of disease and optimisation of quality of life. But there's that critical bit as well around supported self-management in chronic disease and the part that plays in improving outcomes and sustainability of healthcare systems. And then on the right-hand side, of course, we need to understand how we prioritise resource, how we incentivise good practice, and how we achieve balance across that pathway. And the challenges for doing that are obviously different depending on the context of the healthcare system that we're working in. So Ireland will be different to Wales in the levers and mechanisms that you use to finance for value and better outcomes. But common to both of us is the need for good outcome and costing data to sit alongside to inform that decision making, including patient-generated data, such as PROMs. Decreasing unwarranted variation. How do we optimise positioning of drugs and devices and link data on devices to patient outcomes That's something we're very much looking at and are interested in Wales. And taking a much more tailored approach to the individual, you know, a more flexible model of care rather than a one-size-fits-all. And how do we use digital health not only to support new models of care, but to make it easier for us to acquire patient-generated data in a trusted way? And finally, how do we use data to meet true needs and reduce inequalities in health? So why is all this important? Well, particularly now, I would say, and certainly I can share in Wales, we have a real problem at the moment, a real tragedy of the commons, in that the health system is really creaking, particularly after the pandemic. There's a huge competition for resource, and without good data, good information to inform balanced decision making, those who shout loudest or lobby hardest tend to get the resources. And that means we are at risk of disadvantaging sections of our population. So if we accept that there are always going to be finite resources and that the wants and needs of the population are potentially unlimited, that's going to lead to scarcity of services and potential inequity, and there will be choices therefore. So we need to be very certain that the resources that we have are being targeted in the right way to meet the needs of our population. And that's what value is all about, in delivering what matters equitably to people across the population. And yes, that means good quality in services. Yes, that means efficient processes, but it is also about taking that broader whole system view about how we configure care. So another issue I think we observe within our healthcare systems is that we have very strong professional silos. So financial managers might say in response to a healthcare crisis, oh, if only clinicians would just reduce unwarranted variation, stop low value care, stop doing this, stop consuming. And as clinicians, we might turn around and say, well, if only financial managers would fund this and fund that, everything would be absolutely fine. But the truth is, we're only going to make progress if we manage our risks together. So putting clinical, financial and organisational risks together, developing a common language around value and around the data from patient-reported outcomes, clinical outcomes, and putting that alongside costing data so that we can make balanced decisions about what to prioritise, what to deprioritise, how to fund, what to fund, and how do we get the best improvement in outcomes across the piece that we can do together. So I think data and information, knowledge is king, and very much so in bringing together those professional silos so that we can start solving some of these problems together. So how might we do this? Well, in Wales, we have begun to, apart from culturally, drive the use of clinical audit, patient-reported outcome measures and other data. We have created some national data atlases of variation, which increasingly have patient-reported outcome measures in them. They are developed with our in-house informatics team, informed by clinical networks and validated by multidisciplinary clinical teams so that people are comfortable with the data. The data comes from multiple different sources. We've now secured permission to have regular data feeds back from the UK HIPE audits and some of the other national registries and audits in the UK. And what that means is we can start to bring audit and patient-reported data to life by having a refresh of that data and an interactive data tool that everybody can interact with and which clinicians can interact with down to patient level. So as I said earlier, this has got multiple purposes around quality improvement, around deriving insights through which we can design and deliver new services. It is informing policy in Welsh Government around planning for healthcare services and how we finance for health as well. So this is just a snapshot of some of the data products, and we had a very slow start. I have to say the silver lining of the pandemic has been that there's been a much greater appreciation of the value of data and information to support decision making. And that has enabled us, ironically, to accelerate this program of work. So we have a really good pipeline of these products now as a first stepping stone towards everybody using this data on a par with financial and process data. And then finally, how would you embed PROMs and other patient-reported data in this? Well, of course, this cannot be a burden on clinicians or on clinical processes, so you have to work out how you're going to automate this. And it sits very much alongside digitisation of healthcare systems, not just from an electronic patient record perspective, but also in patient-facing technology and how we make that interoperable with hospital and primary care electronic patient records. So in terms of PROMs, we would say there are 5 stages in the end-to-end process. The first is around collection of PROMs, which needs to be embedded in direct care, so it's a meaningful exercise for both patient and clinician, and used as a tool as part of ongoing healthcare. Then we need to link that data. So that's been quite a complex piece of work involving suppliers, national data architecture and health board data architecture in creating an interoperable landscape for PROMs, no matter what device they are collected on. And I'm happy to provide more information on that, because that's quite a big, complex piece of work that the team have been doing. And then once we've got this data, how do we present that? So some of the atlases are one way, but of course you need analysis and development of the questions that clinical teams want answered. So we have some analytical expertise within the team as well. And we also need to present PROMs to support the consultation. So how do we support surfacing that patient-reported outcome in an electronic patient record, for example, and also reflect it back in an application back to the patient so that they can track their own symptom burden and quality of life too. So that's just a real very brief snapshot of what a PROM end-to-end data flow might ideally look like. Really big old complex piece of work, so happy to provide more information on that in due course. And just to finish, this is my favourite quote from Atul Gawande's book, Being Mortal. He says, "Life is choices, they are relentless." And he wrote this in relation to choosing care at end of life, essentially. But it's such a true quote. And without good data and information to help us make those choices, we will constantly fail or get what we've always got. So if this isn't a call to arms for a strategic approach to data and information, I don't know what is, because knowledge is absolutely king. Thank you very much.
Thank you, Sally, for a super presentation. I think we're all impressed with your ability to describe that agility and innovation, and you described it so elegantly and simply. So that pathway to PROMs and PROMs directing care, there's so much echoing with what you said about Wales and the NHS with Ireland at the moment. We're in precisely the same situation. I think we have to adapt and innovate. That we're not going to manage with our current structures and so forth. So, Sally, thank you again for supporting Noca and a super presentation. Just and hopefully Sally will be able to stay on for a panel discussion afterwards. I'm just going to introduce our next speaker, who is a pre-recorded talk. It's Professor Richard Gráinne, and Richard is the head of is the director of the National Perinatal Epidemiology Centre in Cork, and a professor of clinical obstetrics in UCC, and was involved instrumental in commissioning and establishing the new unified maternity services in Cork University Maternity Hospital. He has interests in maternal fetal medicine, epidemiology, health service research, and electronic healthcare records, and has led out on the shared obstetric healthcare record, and is also the HSE Chief Clinical Information Officer, working with the Chief Clinical Officer and the Chief Information Officer. And I hand over to Greg to put on Richard's talk. Thank you.
Hello, everybody. Thanks to Noca and their annual conference for allowing us to present the National Clinical Effectiveness Committee endorsement of the National Clinical Audit for Perinatal Mortality from the National Perinatal Epidemiology Centre. The National Perinatal Epidemiology Centre was established in 2006 by the then Minister for Health and Children, Mary Harney, on the foot of recommendations from the Lourdes Hospital Inquiry Report, which suggested the need for a centre to assess outcomes and data from our maternity services. The National Perinatal and Epidemiology Centre undertake a number of different audits and research in the area of maternity services. The perinatal mortality audit is one of our main significant national annual audits, but we also look at severe maternal morbidity, maternal death inquiry, and we carry out audits for children who require therapeutic hypothermia and for very small early born babies through the Vermont Oxford network. Other work includes assessment of the 10 groups for caesarean section and work around a postpartum hemorrhage quality improvement initiative with the National Women and Infants Hospital Programme. We're fortunate to have a governance committee overseeing our strategy and providing us with direction. And this is made up of members of the multidisciplinary team, but also a patient representative in Ms. Mary Creedon, which supports our work. We know that each perinatal death has a profound effect on a mother, father, and the extended family. We do not focus on just the rates and numbers. We actually look at information behind each of these deaths to try and identify causes and learning, and that deep assessment allows us to generate recommendations for improvements of care, either to reduce the numbers or to improve the care provided to these families. Each of our audits have an audit governance committee, again made up of a multidisciplinary group and a patient representative, Siobhán, who you'll hear from this morning. We're very grateful to all our governance groups for their input and intellectual assistance in the assessment of the data and the learning from that data. This is a trend from our perinatal mortality audit, showing the rates over the years 2012 to 2019. And you can see that the rates have wandered up and down a little bit, but essentially have remained relatively flat. Internationally, this data is quite good in comparison to other countries. However, other countries have actually managed to start shifting their perinatal mortality rate downwards, and we believe the further focus on this issue and the recommendations would actually help us to do the same in Ireland. The maternity services essentially have national perinatal mortality data with this in-depth clinical audit since 2009. And I have to thank here all the individuals from the maternity services who are involved in providing this information and supporting this and other audits. They are the people who really make these audits possible. And specific among those are data coordinators at each centre. They work tirelessly to ensure that we get the raw data that we can then use to do the assessment and analysis. We encourage the use of this data in the units through individual hospital reports, hospital attending and providing feedback through hospital meetings, and the use of the national data set. And indeed, many hospitals have undertaken quality improvement projects for themselves based on the information from these audits. We now have transparency through the identification of the individual audits in our annual reports, and we align all our audits, including this one, with the National Office of Clinical Audit, and follow the standards that they provide for reporting, and they in fact endorse our audits. We also collaborate closely with the National Perinatal Reporting System of the HPO, so that we ensure that the data accuracy with respect to the number of perinatal mortalities for the national statistics. The National Women and Infants Hospital Programme are a very close ally and effectively strategically are closing the audit loop for these audits by working on the recommendations. We continue to try and improve and develop this audit, but with the background view that we're hopefully improving the outcomes within the services. Some of the audits that have progressed successfully include the centralisation of histology reports for standardised interpretation, which allows better classification of placental conditions and better accuracy as to information as to possible causes of these deaths. The hospital groups with the National Women and Infants Hospital Programme have begun to work towards a networked perinatal pathology service so that the provision of high functioning perinatal pathology is available for all families who are affected by these losses. We also believe that some cohorts within the perinatal mortality groups, such as stillbirth and neonatal death at term, could actually have more lessons learned by in-depth reviews. And we're currently working on this particular recommendation with the National Women and Infants Hospital Programme to try and assess these cohorts on a rolling basis. One of the feedbacks that came as an aside to this audit was the delays associated with getting timeliness of autopsy reports where cases are with the coronial services. We have interacted with coronial services and indeed through the Department of Health to try and speed this process up because families waiting for this kind of information are not able to move on with their lives. And so this is an area that's not directly associated with the audit, but has come to our knowledge because of the audit. In addition to those that I've thanked already, one person who has been very involved with this audit from the beginning, and in fact is one of the oldest members of IMPEC apart from myself, is Ms. Adele Manning, who's a midwife by background and who's our audit manager. And Adele has been singularly responsible for the drive to get this audit to where it is today, but also the other IMPEC staff, including our epidemiologists who analysed the data. For the National Clinical Effectiveness Committee, we had to do an economic analysis and we got assistance from colleague Brendan Kennelly and Claire Fitzgerald. We're grateful to the National Clinical Effectiveness Committee for the opportunity to put our audit through their process, but specifically some of the individuals who helped us along the way, including Rosario Lynch and Deirdre Holland, and in the early days of our steps into this area was Jenny Hogan. And I'd like particularly to thank our public patient rep, Ms. Siobhán Whelan, who gives an awful lot to this audit. Knowledge is the insight achieved from processing data. So developing this knowledge is just one step in the continuous improvement program. But I think what we all have to remember is that for this improvement to happen, the knowledge generated must be translated into action. The National Clinical Effectiveness Committee endorsement of our audit is very important. National clinical audits provide a data-driven, objective assessment of practice against clinical standards and in line with the best evidence. The National Clinical Audit submitted for the National Clinical Effectiveness Committee has successfully passed the rigorous methodological processes, including prioritization and quality assurance. And this audit was recommended by the committee for onward endorsement by the Minister. We are grateful for this endorsement and thank you very much.
Good morning all. My name is Adele Manning. I'm here today to talk to you about the evolution of the MPEG perinatal mortality audit. As you can see from these diagrams, they display the different stages that the HSE recommend in planning and implementing an audit, and which the MPEG has mainly adhered to. And I'll discuss the different stages in this short presentation. So the most important part of any development is the planning stage. So within 2009, under the auspice of the National Perinatal Epidemiology Centre, a multidisciplinary expert advisory group was convened, and their remit was to evaluate the perinatal mortality within Ireland and to give guidance on the establishment of a national audit. The audit methodology that was chosen after much review of the literature is evidence-based validated audit tool allowing for international comparison, the perinatal mortality notification form and classification system on cause of death, as developed by CMACE, that's the Centre for Maternal and Child Inquiries in the UK in 2010. Definitions and conventions and calculation perinatal mortality rates are based on national and international guidelines. Prior to implementing the audit, they were endorsed, the methodology was endorsed by the relevant faculties, the Institute of Obstetrics and Gynecology, the Faculty of Paediatrics and the HSC National Clinical Care Programme. A pilot study was conducted using the methodology in 2010 and 3 of the 19 maternity hospitals participated. I suppose a major part and a key factor in implementing an audit nationally is engaging with all the maternity units. Following the pilot study, a national multidisciplinary response forum was held in Dublin, and it gave an opportunity for clinicians throughout the country to give feedback on the data tool and also findings from the audit analysis of the pilot study. All maternity units were visited by MPEC personnel, the Director, Professor Richard Gráinne, and the Audit Manager prior to implementation of the audit in 2011 nationally. So the key factors is the relationships that were established within the maternity units. Senior management were asked to identify coordinators in the maternity unit to collate the data and submit it to the MPEC. Establishing and maintaining supportive relationship for this purpose was key. The data coordinators were provided with training. Data submission can be facilitated either via an online database, a secure online database, or in paper format. And we currently have 17 of the 19 maternity hospitals submitting online. There's ongoing support provided by the MPEC personnel in terms of training videos, reference manuals, educational webinars, particularly following publications of reports, and telephone support is always available. Due to data standards, the MPEC data process management and storage policies are based on the HIPE guidance on a data quality framework for health and social care. The legislation, current GDPR, is followed and data processed is in a pseudonymized fashion. Data quality are the key factors is the relevance. Annually, the advisory group review the data notification form to ensure that it is still clinically relevant. The units, the data is validated with all maternity units. It is also verified at a national level with the birth notification process run by the MPRS at national level, and this ensures that all national data sets and perinatal mortality are accurate. The MPEC aim to have a report on the perinatal mortality within 18 months of the reporting year. However, this does remain a challenge, particularly following the cyber attack, which affected timeliness of submission of data to the MPEC. Data points are consistent over time, and it is comparable with other national data sets and also international data sets. We, for example, in Northern Ireland have a similar data set, as do the UK and some EU countries. National and unit-specific audit reports are available on the website and are disseminated widely. The MPEC data management process is outlined here, from the event happening within the unit, submission of data by the data coordinators, data quality assurance and management within the MPEC, then the development of the reports. Analysis is done by perinatal epidemiologists supported by the research officers, and then wide dissemination of reports to the various stakeholders. There were a number of ongoing improvements since the inception of the audit to date. In 2014, the MPEC aligned with Noca in terms of audit standards. We also have adopted the Noca monitoring escalation policy, and that refers to outliers, hospitals that may be outliers in their findings. However, to date in the perinatal mortality audit, we have not had one hospital that has been an outlier from the national rate of perinatal mortality. We've had a very positive development in the welcoming of a public representation on our advisory group, and also the value of her contribution in a lay summary, which makes a reading of audit findings more easier for the layperson. We also, since the development, have pioneered a national standardised interpretation and classification of placental conditions associated with perinatal deaths, and this is following an international convention of pathology in Amsterdam, referred to as the Amsterdam Convention. The collaboration with the National Women and Infants Health Programme has been very positive, and they have implemented some of our recommendations to date. A very positive step recently is the identification of individual hospitals in national reports. It promotes a culture of shared learning. Key thing in sustaining improvements is maintaining a relationship with all maternity units. Recommendations are being progressed by the National Women and Infants Health Programme, engagement with the Department of Health prior to publication of the reports, and now with the welcomed invite by the NCEC to have our clinical audit endorsed. Has been very exciting. I'd like to acknowledge finally all the healthcare professionals who contribute to the NPEC perinatal mortality audit. Without their help, this audit would not be able to exist. Also to the advisor group for their ongoing guidance in optimising this audit, and to the MPEC multidisciplinary team. Thank you for your attention.
Hello everyone, I'm Siobhán Whelan and I'm a patient representative on the Perinatal Mortality Working Group at MPEC. I became interested and involved with the work MPEC undertake following the unexpected and devastating death of my own newborn baby boy Connor in 2014. My need to know why babies die in pregnancy, during birth or shortly afterwards, and what can we learn from their deaths and do better in the future to help prevent such loss of life. My role as a patient rep is to bring many user experiences from families affected to the table for consideration that might help improve the quality of care going forward. I hope as I've grown within this role and learning all the time that I give a fair and objective representation in this capacity. A core function of the NPEC and their perinatal mortality clinical audits is to improve the care of mothers and babies in Ireland. The learning from these audits helps inform the recommendations needed to improve future practice and policies in our services. The quality of these audits and recommendations relies on the timeliness, accuracy and quality of the information received. Challenges faced time and time again is the slowness to see the implementation of recommendations made, and the need to repeat recommendations in subsequent audits, even with ownership now assigned. Two such examples are the call for funding for protected time for staff tasked with the job of compiling and submitting the information required for audits, and the call for customised growth charts and training. Though some recommendations are being progressed now, thankfully, it is too slow. This is extremely frustrating for all who put so much time and effort into national clinical audits and the learning needed that will improve our maternity services. While it is greatly welcome to see the ministerial endorsement now of this year's perinatal mortality audit as a national clinical audit following the recommendation from the National Clinical Effectiveness Committee, endorsement alone is not enough. We must see actions and accountability now. Clinical effectiveness, simply put, means the right care at the right time in the right place. It requires long overdue adequate investment. The World Health Organization recommendation and the Lancet Stillbirth recall to action in 2016 asked all high-income countries to measure and assess their burden of stillbirth and neonatal death rates at a national level. They also stated that many of these deaths with modifiable factors are preventable with high quality care and interventions. And they ask all high-income countries to implement strategies necessary to reduce their rates of preventable baby deaths. This work is being done through our perinatal mortality audits and the recommendations from the NPEC. However, in Ireland, though we have seen a decline in our overall birth rate over the last number of years by approximately 10,000 births, we have not seen a decline in our perinatal mortality rates. Why is this? And why are we not meeting our obligations to the World Health Organization in this public health emergency regard? And yet during the COVID-19 pandemic, We've seen how quickly we could adapt and respond to and implement funding and strategies needed to preserve life based on those WHO recommendations. We need that same passion, drive, energy, and the will to preserve life in our maternity and neonatal services now. Everyone is entitled to safe, accessible, quality assured care, be it man, woman, or child. These human rights are legislated for at international and national level. We are duty bound to safeguard these basic human rights for all. We must remember that behind every number and percentage in these audits are real lives lost and families changed forever. We must honour them by learning from their deaths and injuries. We must do better. Future service users and their beautiful babies waiting to be born are reliant on all of us to ensure their safety and arrival into this world is at the right time, the right place, with the right care. Governance stakeholders and policymakers, you are the gatekeeper. You hold the power now to change what is right in front of you through this audit and all the preceding audits and the many other investigative processes. You must now act on the evidence before you and provide the necessary ring-fenced resources and national clinical guidance for better, safer, standardised services that meets international best practice and our obligations to the World Health Organization and indeed the National Maternity Strategy. Many simple measures that could save so many precious lives. Let's make sure each mother and baby really does count going forward now in Ireland in 2022. Many thanks for the opportunity to speak with you all today in sharing the patient's perspective, and thank you for listening.
Good morning. My name is Jerry Fitzpatrick. I'm a chair of the National Clinical Effectiveness Committee. And I'm delighted to be here today to participate in the launch of the second National Clinical Audit to have successfully come through the NEC process. Now, NEC is a ministerial committee set up in 2010 on foot of a key recommendation of the report of the Commission on Patient Safety and Quality Assurance. Its task is to promote the National Clinical Effectiveness Agenda through national clinical guidelines and national clinical audit. NEC national clinical audits go through a rigorous methodological prioritisation and quality assurance process prior to obtaining endorsement. And as such, they can be trusted to be designed, developed and conducted to the highest standards. Today's audit on perinatal mortality is the second audit to be successfully quality assured by NEC and thus receive ministerial approval. I want to express my thanks to all who have contributed to the development of this work and indeed to the work in achieving NEC approval. Since 2009, the National Perinatal Epidemiology Centre and the Perinatal Mortality National Clinical Audit Governance Committee have worked tirelessly to produce an annual audit of perinatal mortality. You will have heard from Siobhán, who has acknowledged the work of the audit and the importance of ongoing implementation of recommendations. The patient voice and the public input is key in the development of NEC audits, and I acknowledge and thank Siobhán and indeed other patient representatives who participate in audit development groups. I would like to acknowledge the members of the Audit Governance Group and the staff of the National Perinatal Epidemiology Centre. In particular, I would like to thank Professor Gráinne, Edel Manning and Joy McKiernan. This audit is a testament to the leadership shown by them and indeed the wider team. I also acknowledge all the staff in Noca and in the HSE who were involved in data collection, analysis and implementation of recommendations. Finally, I would like to thank the staff of the Clinical Effectiveness Unit in the Department of Health. They have worked tirelessly over the years in advancing the clinical effectiveness agenda. This audit will now be published on the Department of Health's website this afternoon as the second in the suite of NCEC national clinical audits. And I'm confident that this audit will significantly advance evidence-based care and improve safety for women and their babies in Ireland. Thank you.
Okay, and I'd like to thank all our presenters, and particularly I think Siobhán Whelan's words were so powerful and so clearly describing what's needed, and all the other presenters, and just to acknowledge the ministerial endorsement and all the work of NPEC and our colleagues and that were mentioned there. I'm just going to move on swiftly to our last presentation, is by Professor Edward Gregg, who's head of the School of Population Health at the Royal College of Surgeons in Ireland. Edward is newly appointed, but over the past 3 years, he has served as Professor and Chair of the Diabetes and Cardiovascular Disease Epidemiology in the School of Public Health at Imperial College London. And before that, he led a multidisciplinary public health research unit for chronic disease at the US Centre for Disease Control and Prevention. He's worked extensively in chronic disease epidemiology and surveillance, and is interested in prevention effectiveness trials, the development of natural experiments to study health policies and modelling of health impact and the cost effectiveness of public health interventions. His research is focused on the understanding of the causes, dynamics and prevention of diabetes and its complications, and include long-term follow-up studies, as well as the evaluation of US and UK-based public health prevention programs. And Edward's talk today is going to be on the gaps and opportunities for data to drive action for diabetes. I'll hand over to Edward. Thank you, Edward.
Thank you, Brian, and I'd like to thank you and thank Colette for inviting me to join you. This is actually a great introduction for me. This is my first week in Dublin in Ireland. I'm thrilled to be here. Let me see if I can share my screen successfully. Brian, are you seeing that?
Yes, we're seeing that. If you could just
okay, very good. So thanks again. I'm going to talk about diabetes in particular, and I think, as this group may know, diabetes actually is sort of one of the poster children for the concept of data to drive quality. Really has a very long history, and I think a lot of what we've learned has come from diabetes. At the same time, we found ourselves with the problem, even though we've gained so much from measurement systems for diabetes in terms of its really impact, reducing the impact of diabetes, we found ourselves in a position again where we actually need it more than ever, and we need to advance it more than ever. So I'm looking forward to our discussion here. I'm going to do just basically 3 things briefly. Just talk about why diabetes is a prototypical problem for using data systems to drive its improvement. Talk about the evolution, some of the successes and failures that we've seen along the way, and what are the emerging models and systems, and then what are the opportunities. First of all, diabetes as a prototypical problem. How is it so? Well, first of all, and there's really 3 or 4 key points I'll make here. First of all, it's got diverse and complex morbidity, right? And you're all probably familiar with the classic complications that we've been trying to prevent for decades, right? We think about microvascular complications affecting eyes, kidneys, feet, heart, and blood vessels. But really what we're realizing more and more, partly because of the successes and partly because people live longer with diabetes now, that we really have to think about a broader set of morbidities. And so we have the problem when we think about preventing the burden and the morbidity that follows. We have these high specificity, high relative risk complications that are the classic ones, but we also have a whole nother set now affecting brain, teeth, liver, respiratory systems, bones, that have lower relative risk and they're less specific to diabetes. But when you have a condition that affects 10% of the population or 20% of older adults, it means that actually it leads to quite a burden in these other areas as well. Second is that with diabetes, it's prototypical because there are multiple stages for intervention and that we need to think about. And this sort of gives you, this slide gives you sort of an idea of what the spectrum is. You know, historically, we are concerned about reducing macrovascular and microvascular complications. That's what we're trying to do along with mortality. But we also can think about interventions or measurement that's going to actually reduce the incidence of diabetes, the levels of high risk defined by prediabetes or intermediate hyperglycemia. Or we might think about actually influencing the risk factors, or then skipping back to the overside to the right again, we might think about how we can influence this growing burden or concern about multimorbidity. We have a lot of potential targets, and there's a broad spectrum of where we really want to make a difference. We also have a strong evidence base. There's no shortage, really. There's strong evidence that there are a number of things we can do really with the most evidence, I think, and the longest history aimed at reducing that risk of transition from once a person has diabetes to developing complications and different forms of multimorbidity. But there's also strong evidence that if we can intervene with people at very high risk, that we can reduce progression to diabetes itself, or that we can go to the whole population and try and reduce risk of or the incidence of movement to prediabetes. So we have a lot of potential ways that we can act. And with those, we also have multiple public health avenues. So whichever of those sort of stages we want to target, or if we're targeting all of them, we really have sort of three different ways or sort of meta avenues. We can do it through clinical health services, right, by providing directly risk factor management, or we can try to do it through health promotion by helping people to do change behaviors or manage them for themselves, or we can go at system or population-wide policies that actually change healthcare access, change the environment, change food environment, or other approaches. So, and with all this, in the end, we have a lot of goals that we really want to tackle. And so if we take a broad population perspective, we can treat the whole problem as a pyramid wherein we all have certain levels of risk. And depending on where we are in this pyramid, you know, our goals are to prevent morbidity for those with diagnosed diabetes, efficiently detect those with undiagnosed, reduce risk for those, reduce risk of progression below that. So, and then finally, I think there's multiple stakeholders and beneficiaries when we talk about measurement. So yes, the clinical systems and what we do directly in primary care or in hospitals to take care of people with diabetes is a key piece, but it's even broader than that. You know, measurement potentially affects individuals with diabetes or at risk, families, employers and communities, and then clinicians. And then, of course, health systems managing subpopulations, and then also at the national level or at regional or county level. And that's what I'll sort of focus on here from here on, just what is the perspective and what has evolved in these arenas. So how have data systems for diabetes evolved? So to kind of give a bit of a historical perspective, actually going back just about when I started working in diabetes at CDC, it's interesting to go and look at the data then. And at the time, prevalence was actually about 3% in the United States. And which now we think of as, you know, it's 1/3 of what it is essentially now. And so the idea of preventing diabetes was not on our radar screen, but what was obvious was that people with diabetes had just horrible risks of all sorts of other complications that followed. And the relative risk of amputation, for example, was 20, end-stage renal disease 10. And at the same time, 1/3 of the population had hemoglobin A1C greater than 9%. And then staring everybody in the face was this observation that, well, new big trials showed that if you could control glycemia, you could control blood sugar, control blood pressure and lipids, that you could have a huge effect on that risk of progression. So really what happened at the time, diabetes was not thought of as a public health problem per se. It was thought of as a complex clinical problem, but we started to think of it as a public health problem. And then actually what followed was improving quality of care really became the main vehicle of the public health response, at least in the US. And I think that that was what followed in the UK and other places as well. And so, for example, resources went behind national education, they went behind state programs, and they went behind and through all these really focused on the chronic care model as a way of changing this problem. And then that evolved. Health systems really got better and better at this, and they developed their own different ways of linking self-management support, the way they delivered care, clinical decision support, education, and all of this really hinged on a couple things you see in the middle there. Clinical information systems, data information basically as the core and central. It wasn't the only thing, but if you didn't have that, it wasn't going to function very well. Okay. And then what happened is you had further evolution. So you have expansion of comprehensive care, and then gradually you see systems start to actually become more creative, giving more continuous feedback, direct feedback, use that for epidemiologic analyses and economic analyses, and even comparative effectiveness. Now, the core pieces, the core elements that evolved as the part of electronic diabetes registries, and I think this is fairly ubiquitous. You know, if you go to the best systems, you go to Sweden or Denmark, or if you go to Kaiser Permanente, or even more basic systems, you tend to see what they're trying to achieve is put together these four pieces: outpatient visits with primary care. And the key there is that you're getting the whole population. If you just go to the hospitalizations as a starting point, unfortunately, you miss, depending on the country and place, the majority of people that you're actually trying to influence the preventive and progression of. Pharmacy and lab are the other key pieces. So ideally, you have those four pieces, and then those are going to drive your information on a variety of outcomes, either epidemiologic or sort of population level, or individual level, and to guide clinicians in terms of risk factor management, preventive care. And then you also see linkage to other pieces such as death registries, mortality, vital statistics, as well as other ancillary registries, including cancer registries as well, where they exist. The part up on the right, I would say, is the piece that really hasn't developed yet very well, but that's, I think, a big priority, is how we get patient-centered outcomes and prevention into the mix as well. So while all this evolution was happening, the science actually followed that showed that, you know, not only did we think it's a good thing to do, but it actually is. And there's now been several systematic reviews breaking apart the pieces of the chronic care model and looking at how they influence, in this case, hemoglobin A1C, but you see the same thing for blood pressure control, other risk factors. And what you see is that different pieces of the chronic care model, when implemented, make a big difference in terms of control. And you see that 4 to 5 of these key pieces, these elements, are measurement oriented. The idea of electronic patient registers, patient reminders, audit and feedback, facilitated relay, all those are pieces of that measurement engine that's so important. And just actually recently, this is sort of another example of some evidence for this benefit. This is a study that we did in England and Wales with National Diabetes Audit. Actually, Naomi Holman led this. And what you see over here is, well, the second column basically shows the number of care processes out of 8. And you can see that people who only receive 5 out of the care processes compared to the full 8 recommended in the UK's QAF system, you can see they have a 30%, roughly 30% increased risk of cardiovascular disease, all-cause respiratory death, and diabetes-specific cause, and renal disease deaths as well. So this is the only first study I've seen to actually show and validate the potential benefit. Now, I've been discussing so far sort of health systems perspective, but I also had the opportunity to take a government public health perspective on this. And what we did in the US is develop a national diabetes surveillance system. I should say Linda Geist, a colleague of mine, did this years before, and we evolved it over time. And the difference here is there is a major limitation in a system, in a government system like the US, and that we don't actually have linkage amongst individual level linkage to provide the feedback the way health systems can. But we did form a network style surveillance system that used different sources to provide different aspects of the problem. And we harmonized data and sort of brought it into sort of one ecosystem, if you will. And it used household and surveys for risk factors. It used hospitalization data for complications, vital statistics for mortality, of course, other forms of survey for like telephone and school surveys for risk factors, and then registries for specialized problems like type 2 diabetes in youth and renal disease to feed it as well. And with a system like that, or with any system, of course, we need to be judicious about the data that we use and we go after. We prioritize the following. We basically, for anything to be in the system, it needed to be one of the following. It needed to be either an index of disease burden that's important to people, families, and economies, or it needed to be something that we could change, a modifiable risk factor. You know, we weren't going to go spend a lot of energy collecting and measuring things that were risk factors that weren't things that we could act upon, or they need to be evidence-based interventions that we want to know, are they being delivered? So the idea of quality of care became a part of national surveillance and really should. And then the other category would be safety concerns, harms of treatment. In the diabetes case, for example, hypoglycemia, and that actually ended up influencing the way treatment targets ended up evolving in the US and some other places. The other thing we tried to do, though, was use that data as sort of the core from which you can make other applications to actually influence decisions. So we use it to put out data on an ongoing basis at different levels, national, state, county, but also used it for more advanced statistical approaches for forecasting what the future would look like, for plugging it into disease progression models to understand what lifetime risk would be, and then how interventions affect them and how the interventions affect cost effectiveness and so on. With all this, whether the measurement is how much we can take credit for that influencing this, we have seen, at least in the United States, now this was between 1990 and 2010 and extended up through about 2015, large reductions in the rates of many complications. You can see what happened here to sort of 5 classic. In general, what this showed us was that compared to 20 years prior, that people with diabetes, the average person, had about half the risk of developing a major complication. Now, what led to these is sort of ultimately a subjective debate. We don't really know, but we think that it was risk factor management and this movement towards integrated care, along with better self-care, combined with better treatment, and then also policy changes that really drove this. And that's, I think, we feel that movement and that influence on quality of care in the US and other places actually really paid off in that regard. That said, the nature of chronic disease epidemics is that you can't let your guard down. And even though we saw that reduction of 50% overall, you can see the gaps in care that still exist. And this is what you get from this surveillance system. You see here, if you look at these green bars, basically what that is that, well, it's the number of people with diabetes in the US diagnosed. And as you go down and look at this cascade to the right, you can see the drop off in receipt or in attainment of recommended levels of glycemic control, blood pressure. And when you get down to basically what you end up with is only about 20% at this point this is 2012, met all 4 key goals of maintaining glycemia, lipids, blood pressure, and tobacco. Now, I can tell you that it has not improved. We haven't looked at the new data in 2018-19. Unfortunately, there's been a stagnation in this. This has not improved. So in spite of the improvements in complications overall, there's just a long ways to go. And then the other nature of chronic disease and all epidemics is that they change, they're dynamic, and you have new things emerge. And so along with that stagnation in care and outcomes, new things came on the scene: growing obesity, type 2 diabetes in youth. We have an age divide in a lot of these issues, wherein older people do better than younger people in terms of getting and managing complications, and their trends over time are doing better, whereas in youth and young adults, it's not the case. We have persistent inequalities. We have diversifying morbidity and multimorbidity. And at the same time, we have a number of big opportunities. There's new therapies and interventions, both pharmacologic and lifestyle, new forms of prevention programs. We have massive opportunities with big and better data. The challenge is how we harness it and use it into data systems. But this has really led, I think, that there's a call at a number of levels to really bring data to the forefront. We're doing it here today, and it's nice to see. This is right here on this slide shows what was reported by a Lancet commission that I've worked on, wherein it was really devoted. The key theme was that for the global problem of diabetes, that it is actually data that needs to be brought to the center, such that diabetes mini teams and the different ways that care is organized, wherever you are, if you're in Ireland or the US or in Cameroon, you know, it's diabetes teams, but the idea of different diabetes registers that can link to population data, can link to hospitalization data, and then link out to community services is really one of the global goals that was promoted. And I've been working recently with a WHO recommendation panel that has arrived at a similar recommendation. This is the schematic of priority metrics that WHO is likely to promote, that all countries aim to try to do is really achieve key levels of control across a spectrum, from prevention to better processes of care to intermediate outcomes and then long-term outcomes. And you notice we have a very, we tried to have a very parsimonious list of key outcomes that if we could change them, then you would change the burden of diabetes in the population. So what are the big opportunities coming forward? I've mentioned big data. I think mobile and wearable data is a potential too. We're not there yet with that, just like patient-centered outcomes. There's an opportunity and need to bring in more creative applications at multiple levels, as well as to use these data not just for monitoring to influence policies and patient care, but also as platforms for comparative effectiveness studies. So I hope I didn't overrun my time. I'll leave it at that right now, and I'll look forward to our discussion. Thank you again, Brian, Colette, and others.
Thanks, Edward. And I'll hand over to Mr. Ken Mealy, who's going to chair the panel, a brief panel discussion.
Thanks, Brian, and good afternoon, everybody. And unfortunately, we don't really have very much time for discussion, but I do think the fantastic program today, or this morning, does warrant a few questions. And the first thing, and I actually don't see the questions in front of me, so perhaps Aisling can help if possible. But I want to start the conversation by it struck me today, so many of the talks touched on issues in relation to public health, despite many diseases being managed within an acute hospital setting. And I think it's only right then to ask Michael Madigan, perhaps. At one stage, Michael, you finished your talk by saying, you know, ring 999 if you think you're having a heart attack. And I think Dr. Ronan Margie's data was very clear. You need to get yourself into hospital very quickly. Understanding the data we have, how do you think we can actually get the public on board and educate populations to do what you said, ring 999 as a matter of urgency?
Thanks for your question. I think it's very much not reinventing the wheel. The stroke campaign about FAST, very effective. Everyone talks about it. Everyone is aware about it. I think if there was a similar public message campaign to highlight the benefits of calling 999 immediately if you think you're having a heart attack, and getting to a hospital that can treat you is extremely important. But yeah, it's really about getting a message out there that people are going to remember and people are going to follow through on it.
So that public health messaging must be tied into all of our audits. So thank you for that. Sally, can I come to you? You at one stage you mentioned about managing risk together. In relation to
Ali had to leave, Ken. Sorry.
Okay, so
yeah, apologies about that.
Can I move on to Edward then? Edward, it struck me when you were talking the huge breadth of data collection that you were discussing, particularly in relation to diabetes. But in terms of healthcare systems, is there any metric or is there any proportion of healthcare spend that we could use to indicate, you know, how much we should spend on terms of data collection, audit, and quality improvement?
You know, good question. And I have not, that's such a hard thing to measure. And I don't have an answer to that. I think that the perhaps what we can point to, though, there is cost effectiveness data that shows us that managing the basics for diabetes tend to be very good value, right? If you manage blood pressure, you save money. For individuals, it's actually cost savings. If you manage glycemia and lipids, it's very cost effective, and for a variety of reasons, basically. And I think the challenge then is us figuring out how much it actually costs. How can we make the measurement efficient and cost effective? I suspect that it's a heavy startup cost, but once you get it going, it pays for itself.
And I guess that really is an important point, and something that perhaps Colette will touch on as she sums up this conference. How do we get that data collection efficient? I think we're all won over on the cost effectiveness of clinical audit, saving money by producing safe, efficient care. I really do apologise. We're well over time, so I'm going to hand over to Colette Tully, the Executive Director of Noca. I think we all have a depth of gratitude for Colette and her team, who are passionate about what they do. Colette is going to sign off on the conference this morning, and she's also going to tell us the name of the Quality Improvement Champion Award. Over to you, Colette. And thank you again to all the presenters this morning. Really fantastic presentations, really enjoyable morning, and I hope all of you have enjoyed it also. Thank you. Over to you, Colette.
Thank you, Ken. Just going to share my screen. Is that coming? Can everybody see? Yep. Okay, we're good to go. Okay. So before I start and thanking people and summarising the day, I'd just like to get the QI piece. That's my first task. You know, we were really amazed at Noca. We had 14 submissions, and in the times that we have come through between COVID and then being hit by a ransomware attack, it was just a testament to the commitment of people on the front line to collecting data, but also more vitally to using it to make things better. We had a really broad range of topics right across and from right across the country. And I think, as you can see from the submissions today, they focused on data quality, which can sometimes be neglected and not seen as the exciting part, but is absolutely the cornerstone of then having good, reliable data to select and do your quality improvement projects. We had then a really good example of the change to the system with the virtual knee clinic, and that system, that nobody works in isolation, you're part of a bigger system, and that piece. And then we also had the example of improving care at the bedside. All of these submissions are all put together into a booklet and will be available on our website, so that all of the learning can be shared right across the system. Of our 14, we had our 3 presenters today. There can only be one winner. So the first of our highly commended awards is the University Hospital Water fast track knee pathway, and congratulations to everybody who was involved in that. Our second highly commended was the data quality project around stroke, and that leaves that our winner, and it was very, very close, is the High Heel initiative from the Matter. So congratulations to everybody involved in that. It's just a wonderful example of how you can really, you know, and the involvement of the patients in their care as well. We just pipped it at the post. So again, congratulations. I just, to Ken's question about, you know, sustainable audit and everything else. Before I go into that, I suppose today, this conference, to me, there's 3 things that doing. The first bit is to acknowledge the commitment of staff to using data to make things better. And I suppose that's why we exist. That's why we're so passionate and committed to what we do. And most of those people, some of this is done in their own time. And I know Siobhán Whelan called out that need for those who are the funders to really, provide more time and resources for those people to actively collect the data, but to use the data. And that's something that we all need to, we continue to advocate for. The second piece is to demonstrate the impact. It takes time. National Clinical Audit can be, it takes time and money to produce this data and to distill it down. You see today something on one slide with a couple of beautiful graphics, but to actually make that, there's a very famous line, I think, from George Bernard Shaw, sorry for the long letter, but I didn't have time to write you a short one. And I think that's what really takes to be able to take data and thousands of rows and distill that down into a beautiful image or graphic that's really digestible for everybody. That, I think that's the real skill in this. And when we can do that, we can really demonstrate the power of our audits. So not only for changes at a system level, but also driving policy change. And I think what's really come across today is really the power of this data for public health messaging. And through Michael and Ronan on the heart attack audit, just that, I hope today that, on the radio this morning, a lot of people eating their cereal popped their head up when they heard Michael say about call the ambulance, dial 999 if you're experiencing any of those systems. And that public messaging is across all of our audits, and it's something that we're working with all of our public patient reps and different organizations to really start to promote the use of our data, because it's an untapped, I think we're just starting to tap into that, the value of that information. And then I think it's brilliant to have Sally and Ed here to lift up and look out and see what's happening in the world and to learn from where others are doing internationally, and also to share what we're doing. So it brings it all together. I look forward to next year when hopefully we can have this conference in face-to-face in the college. And finally, to answer Ken, your question, Brian presented on the first 10 years of Noca, and so much has been achieved with help from so many people. But if we were to look at what's coming, what are we focusing on? And we did a number of sessions with stakeholders as part of our strategy, and what really emerged was the burden of data collection. It is very, very difficult. We still have a lot of paper records. We lack an individual health identifier. We will be pushing and advocating for an individual health identifier, and also for electronic health records where we could extract that data, collect it once at source and use many, many times. And that's, I think, where the real, that adds an extra cost to clinical audit in Ireland, because we have to put a lot of bodies to collect the data, rather than technology really helping us out there. So in future, I think that it would mean we rolled out audits much faster, and it would also reduce the cost of our audits. We want to expand beyond the acute care setting, and I think that's a given with Sláinte care and integrated care, and the episode of care. And Ed pointed that out. If you were just capturing chronic disease management from the episode of hospitalization, you'd be missing a whole lot of it. And the same with after the acute episode. So that's something we're going to work on and push forward for over the next few years. And then the next piece will be getting our data out there, not just waiting for a report that's 18 months old. We need to get our data out we're aiming for quarterly dashboards, so that those 14 submissions that we've seen today, that just becomes a normal part of how you do your job, getting access to that data on a regular basis in a timely manner, so that you can really drive improvement. I don't know about how we get sustainable funding, Ken, but there's lots of different options, I think, to spread the cost of that throughout the system. And we're very conscious of keeping our data sets lean and trying to come up with really good IT solutions that we can use multiple times for all of our new audits. So we work away on that. Finally, I would just like to say a big thank you to RCSI for the support they give us, to the HSE and Colin Henry and his team, and we look forward to working with the new Clinical Audit Centre under Dr. Orla Healy's guidance. We'd also like to thank the Department of Health for all their support and promotion of National Clinical Audit, especially through the work they do in developing national guidelines and setting standards for national audits. I want to thank the Noca team. I say it every year, we're small but mighty, and indeed we are. We are a small team, but we also have a huge team of volunteers on all of our committees, right across all the various pathways of care that relate to our audits, as well as our PPI reps. And a special thank you to Michael today. He gave a fantastic presentation. I'd also like to thank our clinical leads who, again, most of them are in a volunteer role, and they give up their time up to help us write these reports and lead out and provide that clinical leadership for our audits. I'd like to thank the audit coordinators in each hospital, and they have the unenviable job of collecting the data for us and going to those paper charts in the main and going through that data. And they're an amazing group of people who are just so committed to getting that data right. I'd like to thank all of the speakers for giving us your time today and for some really amazing presentations. And I'd also like to thank there's one powerhouse behind this conference, and that is our comms and events lead, and that's Aisling Conley, who just makes this happen every year and does all the beautiful slides and the graphics and tweets in the background and engages with the media, and just and does this, you know, she's a powerhouse when it comes to this. So Aisling, this wouldn't happen without you, so thank you very much. And finally, to everybody who's attended today, thank you for your continued commitment to clinical audit. It's what keeps us going too. We feel like we're doing something and making a difference. So thank you very much, and I wish you all well.